So welcome everybody in the room and online. My name's Robin, and I've been working for Doctors Without Borders, Médecins Sans Frontières for 20 years, but I'm not a medic. And so it's also my role to bring the conversation down to an everyday normal level rather than a highly complex technical medical level. We're just going to run some sound checks and visual checks to make sure everything's okay. In the room, can you hear me in the front? Can you hear me in the back? Is it all good? If it's not good, do say so, because it's very frustrating when you come to an event and you can't hear what's being said. Welcome those who've just arrived. Bienvenue, bienvenue. Have a seat, have a seat. And if you want to speak in another language, between us, we speak most languages. And so it's okay to intervene in any other language if you have questions. I'm going to look to the online audience. I can see there's a camera, which I think is up there. And I don't know if somebody in the room is watching online to make sure it's okay. I'll just double check. Yeah. Do type in the chat. Interacting online, I think you can type in the chat if you want to ask questions. Is that how you're doing things? Yeah. Good. Okay. Allez. So welcome to this discussion event. Thank you for braving the weather. It's not so nice outside, but hey, we'll get over it. Good. So we have a quick look at the agenda on what we're going to do this afternoon. Behind me, we've got 4 points: a panel discussion on the climate, environment, and health, one on conflict and migration, and one on a gastro-SAM story. SAM stands for acute severe malnutrition. And so that's, well, I shall be discovering it along with you. Good. And I think before we go on, let's have a bit of a word of an important person. I think most events start with words from an important person. So the important person we have today is Amrish. Where are you, Amrish? There we go. Come along and be important and say an important word. Give a round of applause. Look at that.
Thank you, Robin. Not such an important person, but always interesting to kind of like be announced as that. Welcome, everybody. Also on our behalf, I'm Amrish, and I'm the director of LuxOR, the Luxembourg Operational Research Unit. And I think, research sometimes sounds a bit abstract, and what we're trying to achieve here today is to kind of make it a bit more translatable. Why is research important? How does it help us? And does it only help MSF, for example?
And why is it in Luxembourg?
Exactly, and why is it here? So, Robin, over to you. Or do you want me to take
No,
it away?
go ahead. Yeah, take it away.
Okay, I'm going to try not to have long of a monologue, but so research, I think that's why you're all here, because you're kind of interested in the title of the session and you want to see or understand better how does research help a medical humanitarian organization such as MSF. I think in first instance, we're very privileged that we are able to do research. And when you think about research, you immediately think with a medical organization about medical research, helping our patients or helping us to treat our patients better. And how does that look like? Well, it can happen in many different ways. Improving patient care is one of the core principles. And as you might imagine, many of our patients don't have access to quality care. And there's many reasons why that is the case. Often it's the lack of, for example, highly trained healthcare professionals, but obviously fundamentally it's always a lack of resources, financially, HR resources, the fact that we have very fancy laboratories, for example, in Luxembourg, really well functioning laboratories that within a couple of hours can give you an appropriate result if someone has a disease or not. That's something we don't have, that luxury. And how does research help in all of this? Well, research helps, by kind of looking at what of existing technologies could be translated so that we can implement them in settings where you don't have very comprehensive hospitals, where you have, for example, always really highly trained laboratory professionals available. But also, it helps with doing the advocacy around that. Because obviously, it's also true that there is sometimes a bit of business behind products that help us. And sometimes these markets of people that are underserved are not the most interesting markets. So our advocacy to kind of push this, to say, well, if we want to help people, we need HR capacity for that. We need tools and technologies that can help people, but we also need to kind of systematically document, for example, on diseases that we're actually quite unfamiliar with in Europe nowadays, but that we see still quite a lot in the areas where we work.
I'll stop you there. Can you walk us through a kind of an example of where we've done some operational research linked to patients that we see in a particular country, and where we've used that, we've leveraged this research to make a difference from an advocacy perspective. Can you give us an example? Over.
I'm going to give you, I mean, there's many examples, but I'm going to use some examples that also speak to the imagination for anyone who's ever traveled to a country, for example, where you see malaria. And malaria is a very old disease, as we know, and it's transmitted by mosquitoes.
I'll stop there. Raise your hand if you've had malaria in the audience. No, what? There we go. Yep. Let's not be shy about it. Some of us have been there. It's no fun at all. And so we're all exposed to this before.
Malaria is also a disease that is often exemplified. If people ask me, like, or the community that works in malaria, what's actually the biggest killer? It's that mosquito that transmit the malaria parasites to patients, especially children under 5 are very susceptible to get a very severe disease and die. And over the last 15 years, a lot of progress has been made in many ways. On the treatment side. So how do you actually get the appropriate medicines that work? But also not just how do you have an array of pills, but how do you make sure that in an area where people cannot go to a doctor and say, hey, can you diagnose what I have and give the appropriate treatment, that people can also just go and get these medicines themselves, and that you kind of make the label simple enough so people can actually administrate it. What MSF, for example, pushed a lot for is what we call the rapid diagnostic tests. And what are rapid diagnostic tests? They are these really small cassettes. You have a drop of blood on it, and it will tell you with a bit high level of reliability if you actually have malaria or not. At the time, there were not so many of these tests available.
So this is not dissimilar to a basic pregnancy test, is it not?
Absolutely.
That easy to use and very low entry-level technology.
Exactly. And these tests are also, for example, resistant against higher temperatures. You can conserve them for a longer time. And at the time, there were not so many of these tests available, but MSF did a lot of what we call field implementation. So it's not that MSF developed the test itself. That was done, for example, in academic institutes, in pharmaceutical institutes, but we helped to see how can you implement that in the many different contexts that we have. How do you bring that to your facilities? But how can you, for example, also develop approaches where actually people get the disease, but they never will go to a health facility? Because the health facility is way too far away, or people don't feel sick enough yet. And that's kind of the treacherous part of malaria. For a long time, you can feel very well, and in a couple of hours, you can become extremely sick. And I've seen it, for example, with kids that were, 3 years old, running around, playing. An hour later, they're sweating. The levels of what we call hemoglobins, or the red blood cells that they need to pump and transport oxygen through the body, are extremely low. Here, they would have been admitted directly on an intensive care unit, and they would have get a blood transfusion and appropriate treatment, but there it's not possible. So actually, we bring these treatments also to the community so that when a test is possible, people can be treated in the community, and you bypass kind of like the need to kind of go to a health facility.
So if you talk about the operational research angle, how did MSF facilitate the rollout or the raising awareness of Paracheck or
So what MSF did is actually pilot a lot of these approaches in the past. And I'm talking already about 10 years ago. And why do I talk about something about 10 years ago? It will link a little bit to the thematic we discussed later on how old infectious diseases, so diseases that have been there for millennia, are now kind of making a return because of funding cuts, of interventions not being implemented, and they become increasingly important. Malaria is, up to date, still one of the biggest killers when it comes to children under 5 years of age. We have a large toolbox of interventions around it, but it's not always easy to implement them. And that's where research kind of helps you to see, okay, we have all these tools in our toolbox that we can use, but which tool do you need to use when and where? And research is actually the way that we generate systematic evidence that, for example, feeds into medical guidelines, so that our doctors in the field, our public health professionals, actually have a bit of a guideline of like, okay, I see so many cases. Now I need not just to have the rapid diagnostic test, but I also need to make sure that I distribute bed nets, and that, for example, I focus on high vulnerable groups, the children under 5, but also, for example, pregnant women. And that's one of the roles of research. There's countless examples of that. And maybe it's a bit good to kind of zoom out a little bit as well.
Because I'm hearing you say that there's not only specific molecules or specific diagnostic tools, like a rapid test, but also models of care with combinations of different, like long-lasting insecticidal nets and particular types of protocols, etc. And all of this, so how do we conduct operational research? How do we go about it, practically speaking? If you could take an example and a country or a project in particular,
Yeah.
to carry on with the malaria idea, the malaria theme?
For example, like I said, we have many tools for malaria, right? So we have the drugs, the medicines that we can give to people. Then we need the diagnostics, the rapid diagnostic tests to treat people. We have the bed nets, but you can't always use the whole toolbox everywhere. It's way too expensive. Also, the malaria burden is not equally everywhere. Malaria is, for example, disease that you kind of see not so much at high altitudes, but you see it at lower altitudes. You see it closer to water bodies. You see it more when you have a rain season that is a bit more heavy. And if you look at the process of how do we do that research, it's basically, it can happen from anywhere. There's a lot of global bodies and national research institutes that do research and sometimes partner up with MSF to look at how can we implement it together. There is sometimes also something we just see from practice. That's exactly what is the difference between classical academic research, which is more curiosity driven. How does this work? How does this molecule work? Versus operational research, where we see a problem in real life and we try to document data, maybe biological samples, to actually perform research so that it gives us answers to directly improve practice.
And so that's the first thing you said. It improves the practice of the day-to-day operational
Absolutely.
medical work that the teams all across the world within Médecins Sans Frontières work, but also we'd like to spread the love and share the knowledge. How do we do that?
So we do that in different ways. Foremost, like research doesn't happen in a vacuum. It's not that, for example, in our team, we say, okay, we need to do this project and everybody needs to listen and we're going to do it. Research helps, is being built up, first gathering what is actually the knowledge gap that we have. What have others done in this arena, what we call literature research? And then when we see there's clear research gaps, that's where we kind of work together with our colleagues within the projects, with the ministries of health, sometimes with academic institutes or research institutes in the country to kind of make sure that we complete the research together. Many of you might know that one of the outputs of research, for example, is scientific publications. And one of the things that I always think I'm very proud of that MSF decided, everything we do needs to be open access, which means that any publication we come up with results and research findings goes on a website which everybody in the world has access to.
I'm going to put Sonia on the spot now. Sonia, you don't happen to have the field research website?
The science portal.
The science portal. If you could project that and then drop the link in the chat, that would be great fun. Not necessarily now, but at some point I can see it. Because it's great. It's an important point to make. So for us, when MSF does operational research, we don't want to monetize that. We want to share.
Absolutely. It's a core principle that we have. And me, myself, being still a part-time academic as well, I've always put a lot of pride in that. When we generate knowledge, we want to improve things and we want to share that knowledge so that everybody can benefit from it. And ideally, I would like to use other people's knowledge as well. And one of the core principles is indeed everything we do being open access, not just at the endpoint, but also, for example, when you do a study, you have to write a protocol where you lay out every step that you're going to do. All our protocols are open access as well. And people that work, for example, in another country that we don't work at could use these protocols to actually implement that research in a different context, for example. A different country where you have a different type of disease or a small subspecies of the disease. And it's quite nice. Obviously, just coming back to your question, how does it look like to implement research? It's not easy. We work in some of the most complex areas in the world. Often also conflict areas or where you have an outbreak ongoing where many people die. And to try to implement research in these settings is quite complex.
Why? Is it because basically the focus is on treating the patients in front of you and that must be the number one effort?
Absolutely.
And so it's hard to take time for us clinicians to take time to step back and look at the macro and perform research too. So you end up running with parallel teams, one on the research and one on the, is that how you do it?
Well, that's obviously often one part of the problem. Another part of the, and that's a good thing because the focus should always be on saving lives and on the patients. But we work together, of course, in teams that we also know that when, for example, an outbreak of Ebola is happening, and you all know that Ebola is one of these high-level pathogens where that you have to take extremely serious. And there the focus needs to be on patient care, but also finding cases in your community. But at the same time, when you have an outbreak, it's also the one unique opportunity where you can learn on how to do things better. From patient care to how do you find patients, how do you build community trust, which is essential to stop outbreaks. So that's how we provide the resources, the people that actually have good understanding of like how our medical work is being done, how not to interfere with that, but at the same time, do implement research in that unique opportunity. So when the next outbreak happens, we can do our job really well. That's also why we work closely with local actors in a lot of our research. That's also when you do research, there's of course a lot of questions about ethics. A patient that, for example, you need data from or a biological sample needs to give consent. You cannot just take it and say, well, I'm going to use for research. And MSF is also one of the highest standards, has set one of the highest standards when it comes to ethics in humanitarian settings where patients and populations are at their most vulnerable, of course. And that takes time because ethics is not just something we do approvals for in MSF, but you need national ethics approval as well, because every country has their own regulations. And to be accountable also means that you need to comply with national legislation. Are you allowed to take those samples? Are you allowed to export them out of the country? Or can you look at the samples in a laboratory inside the country? And bringing all these pieces together in often very high stressful environments is not so easy. But I think MSF is in a unique position to do research, to do it well, to work, especially work with local actors on that front. And that's something we've been doing over the years. I think Sonia is going to put the science portal up in a bit, and I invite you all to have a look at it. Collectively in MSF, we publish as much as a large research department at big universities. And all of the research that we do is not, it really has a fit to purpose. And that's something we are really critical of because, of course, you invest time, money, resources in this. And there's good examples of how research has not just improved patient care, but research can also be used to advocate, to systematically collect data from areas that nobody else is working in is really important. I can give you one example quickly. War and conflict will come back later in the setting, but to kind of better understand like how to treat patients in an active war setting, and unfortunately at the moment we have a lot of these contexts ongoing, says something about how can we, for example, make sure that we treat patients properly and provide the facilities that are needed, even though that access is quite often very complex in these settings, but also making sure that we actually document what has happened. What trauma did the patients have? It says something about the fact of like how did a war conclude, and that it's really an ethical obligation as well. Documentation and feeding and data-driven advocacy, not for the purpose of accountability. That's not MSF's job, but it's incredibly important to make sure that this is recorded, for example, in medical journals, and that's something we do as well.
Because it's written into the charter of Médecins Sans Frontières that we both provide healthcare and witness témoignage.
Absolutely.
And so that's very much a part of that. And recently I read a paper that came out of Gaza, which was just documenting the types of injuries that we were seeing in the clinics, not necessarily to do any prove any clinical approach or anything like this, but simply just to document it for reference.
Absolutely. And I must say it has become also harder in a world where as scientists we try to be objective, and in any way we should be able to document what we actually see as clinicians in terms of trauma. And it's important to kind of bring that back to the medical community, because the medical community does carry a flag of neutrality by purpose. But to do that in these contexts is incredibly complex, because just as with the outbreak that we discussed, clinicians are busy saving lives. Actually, clinicians are targets as well. And it's very complex to document data that can also be used, for example, for other purposes. Again, not MSF's job. We just want to show what we see, what is happening to our patients, what is happening to our medical staff. And doing that systematically is really important. And again, that's where the methodological approaches come in that research managed to utilize.
So can we imagine, practically speaking, there are some situations where the clinicians are working, we gather data through our electronic medical record systems and our health information systems, and we use this data to make analysis, and then we can perform research around that. But sometimes you actually have investigators on the ground, principal investigator on the ground, working alongside the clinicians, and the learning happens in real time, but also is published out in scientific journals. Have I understood it correctly?
Yes, actually, and that's a nice thing. Operational research, if you will see a large part of the team sitting on the stage together with other speakers today. Everybody has different expertises. We have also a general expertise, which we call the transversal expertise, epidemiologists, for example, that we have in a team that really look at improving data quality in the core purpose, of course, to understand how can we deliver care better, at the right moment. But at the same time, this data also feeds, of course, in research. And it's not what we put, we don't put extra pressure on our clinicians because rightfully so, their job should be on taking care of patients. And that's where we also have our colleagues in the projects that are, for example, data encoders, data managers, epidemiologists that really support the systematic documentation of this data. And it's not just like data as the ones, zeros, etc. There's also qualitative data, and I'm sure Umberto later will talk much more about it. How it's really important to also look at, for example, testimonies, or kind of better understand what people have experienced, or quite important, what are actually barriers to healthcare that people experience. Are there stigmas, for example, in the community that prevent people coming to the healthcare to take healthcare in a health facility? Are there stigmas in the community that resonate to all of you as well when we talk about misinformation, vaccine skepticism? All these mechanisms can play a role quite often and really make the medical job of public health professionals quite difficult, because we know that the science is there and the results are published and it's incredibly safe to use these vaccines. But if you don't speak with communities, then obviously nobody will come to your facility to get vaccinated. And that's also a really big part of the work that MSF has been doing well before COVID, and where we have a lot of experience coming in, and why, for example, many of our team have social scientists working in different disciplines that really understand that part of science as well.
For me in Chad in 2005, it was bicycles. The problem was access to healthcare centres. One had to travel a long way. And so we ended up training a whole series of healthcare workers to cycle out long distances into the community with a little box on the back of the bicycle with malaria medicine and health checks. And so it was nothing to do with the science. It was much more to do with the social structure. And so that's part of it as well. So you're telling me that when we do operational research, we look at holistically the whole picture.
That's definitely what we're trying to do. We sometimes have to look very vertically. How does this drug work? Specifically, super technical. But obviously, when you want to implement something, you need to zoom out again. How do populations perceive it? Can you implement it? But also, is it affordable? And that's also a large part of the work that MSF does, is really pushing that advocacy around, hey, it's great that we have really expensive treatments, but we have a lot of people that could benefit from a treatment in areas around the world where money is not high pitched. So we talk a lot about access to this as well. And we have a large advocacy agency on that as well. Yeah.
So a little sound check. Online, everything okay online? I'm just double checking with my colleagues in here. Any comments or thoughts in the chat? Do type in the chat if you've got questions or comments. In the room, can you just show me a wave of hand if you've been involved in operational research at all? So one or two small hands there. Okay. For fun, can you tell us what operational research you're involved with? Just introduce yourself. Say hello.
Hi, Carolina. I work for the Luxembourg Red Cross on operational research. Our focus is shelter and settlements, but I'm looking now specifically at the positive externalities of adequate shelter and settlements, namely public health.
Say that again slowly.
Oh, sorry. I had a tendency to speak too fast.
The research.
I'm looking at the positive externalities of adequate shelter and settlements, and namely public health, so environmental and urban health. So yeah, I've conducted a couple of pilots in the different locations where we work on subthematics linked to that.
Fantastic. And there was another hand that went up somewhere else. There we go. Please, once again, just for fun, it's nice to involve the audience. What do you do, and what's been your role in operational research?
Sure. Hi, my name is Anita. I'm currently a doctoral student at the University of Luxembourg, but my experience with operational research was in my previous life when I worked for the Clinton Health Access Initiative. I was part of the vaccines team, so I was working on a couple of projects, but one of them was looking at vial sizes. So for reaching communities that are quite far out, instead of having a 5-dose or 10-dose vial, there are like efficiencies around like product choices. So that was part of the research.
I remember having run vaccination campaigns in Ethiopia many years ago, and the vial size was crucial because if you've got some left over at the end of the day and it's been out of the cold chain, you lose it. And so it's all about getting good vial sizes. You can be efficient with the way you're. So that's what you were looking into here. Okay, doke. Thanks very much. Any other hands that went up here on the left-hand side of the room? No, there we go. Do you have any questions for Amrish? We're trying to paint a picture of what is operational research in the context of the work that Médecins Sans Frontières does. And what it involves, the practical side of things, and why we do it. Are we succeeding? If not, tell me, raise your hands if you have questions. Here we go. And do please introduce yourself. And that's fine, it's fine. I enjoy running around.
Soll ich Englisch schwätzen oder? Wieso schwätzen? Lützebusch. Okay, well, I have a question about the use. I'm happy to hear that you give the, is that still the paracheck that you use for the malaria test, rapid test? Because I used it first time in my last malaria in 2006, so it's already 20 years ago, but we had only, I think, about 10 tests only for us expats. So it makes me happy to hear this. But how is, at the time, it was only for falciparum. Is it still the same? I'm 20 years out of it now, so that's fine. Okay,
that's an excellent question. So the Expo is linked to what you were saying about vial sizes and stuff. And so how long does do the medicines last before they expire? And yeah.
So, I mean, that's a very interesting question. And there's actually a lot of research done, especially around malaria, of how are medicines actually stored. And I think that that's one of the crucial parts. And I think like that's why we have our pharmacy colleagues in MSF that are also experts in not just like bringing vaccines in what we call cold chains or really cooler boxes, but also how do you store medicines correctly? Because it's not just temperature that has an influence, but it's, for example, also light. UV, for example, is detrimental. And just coming back to your questions on malaria tests, well, you know, when I started working in malaria, which was 2007 up till date, the number of tests has exploded, and the costing price went, you know, all the way from what was at the time $3 down to 20 cents. And it is true that about 80% of malaria is actually diagnosed by rapid diagnostic tests. So they're incredibly important to be used. And for falciparum, you have specific tests. So falciparum is a type of malaria parasite. You have different malaria parasites. What we call the deadliest one is falciparum malaria, Plasmodium falciparum. And the tests work with relatively high, what we call sensitivity. So they're quite sensitive. Also, what I mentioned, a drop of blood, small fluid in there, and within 10 minutes, you have a pretty reliable result. But what we also do is, for example, not just test people once. It can be that sometimes people are negative because you don't have so many parasites yet. If you wait 8 hours, for example, you could find someone actually becoming positive at that time.
And then specifically on the lifespan of these tests, which was really an issue when we first started using. I remember from 2005 in Chad, you'd had to, quickly. Now, do they last longer?
So there's a lot of variability in tests. So I said, like, you know, if you store them at the optimal conditions, many of these tests can now be saved for up to a year, which is quite long. I mean, within a year, you are able to do resupplementation. And also there's like large distribution networks for malaria tests now through local health facilities, national health facilities, etc.
Okay. Thanks very much for the question. Another one over here. Please introduce yourself and ask your question.
Hi, my name's Tony Steffen. I'm going to ask a global question for a global organization. So if you're not, you know, the most suited person to answer it, I understand. Okay. MSF works in many contexts, in many kinds of interventions. Can you describe some of the practices and resources in the organization that are in use to ensure that as an intervention is planned and executed, that the best practices are being implemented?
Would you say best practices in terms of clinical best practices or more in terms of operational research and ethics and things like this?
I'll leave it open-ended.
Okay. Amrish.
So, okay, I can start for the operational research side. So, like I said, we're very stringent in how we implement operational research. And it starts with being very critical. Is this a question that MSF should answer, knowing that research is being done in many bodies across the world? Is MSF really uniquely positioned to answer this question? And then we, of course, look at, like, you know, how much resources will it require? Is this project really the place where you need to implement this research? For example, if it's a malaria project in an area that is in active conflict, well, we work in, you know, about 70% of the countries we work in as malaria. So maybe that's not the best context. And then the other part that is really high in due diligence is the ethics, and making sure that the research that we do actually contributes to something that can improve practice, it being patient care, it being advocacy. And it's also very important to notice that we actually work a lot with global expert committees. For example, WHO, the World Health Organization, has many clinical experts groups, many expertise groups in public health. And MSF is almost always part of those groups, to give technical guidance, but also learn from our peers there that have different experiences. And it's also something I think we've become better in doing, being engaging with the global body of stakeholders, not just in the World Health Organization, but also academic partners here in Europe, overseas in the US, but especially closer to where we actually run operations.
Do we have our own internal ethics review board?
Absolutely. We have an ethics review board that is actually running for more than a decade now, which consists of people that are not paid by MSF to guarantee their independence. And we always call them our critical friends. So they need to keep us sharp. They need to be asking, how are you safeguarding the care of the patient? How are you going to deal with, for example, if you try a new treatment and there's an adverse effect, that patients are being properly followed up? And sometimes it leads to delays because obviously you have an ethical board in MSF, you have a national one, and they do both need to go give approval. So you come up with a protocol which takes quite a long time to develop, and they are going to review these protocols and they're going to give you many comments, and it's back and forth. But like I said, we work with some of the most vulnerable communities in the world. So it's really important for us that we do our due diligence towards our patients and the communities.
But on the flip side, we also capacity build. If I understand correctly, you run one of the toughest courses in MSF. It's reputed as being a real, and so you train clinicians, MSF clinicians, to learn how to conduct operational research in an ethically appropriate manner. And tell us more about the course.
So it's not just clinicians, it's anyone with a healthy research interest. And obviously, you often see that the questions come from the people that are working in the projects, right? And what we try to do once a year is kind of do an open call within MSF to our national staff and ask them like, hey, we're running, for example, in the end of the year, a course on antimicrobial resistance. So do you have any interesting research ideas that you would kind of work on, but you might not feel very confident yet in how to write a protocol, how to do analysis, for example? And that's why we have mentors, people that have done research for years, that kind of help them in a period of 1 to 2 years to really go from research idea to protocol to actually the final dissemination of research.
Do we have any graduates of one of those MSF courses in the room who can speak from experience of? No? Well, anyway, I've seen 1 or 2 people come back from that course exhausted. And so I think in answer to your questions, which is an excellent question, I think it's both the capacity building side, so teaching and initiating people, clinicians, but not only, but also the very, very stringent internal ethics review board side as well, covering both sides of things.
Maybe just to make a small point, we also work with universities in developing these courses. For example, with Utrecht University in the Netherlands, we've developed a course on ethics and equity in humanitarian operations. So it's not just about research, it's also about medical ethics. This year, we're going to pilot the first course, for example, on public health and humanitarian emergencies, not for medical or public health people, but people that, for example, work in communication, that work in policy, that work in logistics, all these key support mechanisms that kind of need to get a good understanding of how we implement public health activities. So it's not just research, it's also a lot on education, a lot on training, a lot on advocacy. So research is much richer than just those vertical elements that you might know of maybe a boring research paper.
Yeah, I'm beginning to have fun, and so I'm tempted to carry on, but I'm mindful of the fact that we've run to the end of our first session. But I'll take one more question if there is one, specifically for Amrish, on operational research in the bigger sense of the term. Please.
Mine is kind of a follow-up question to the answer you just gave, because sometimes we are working with complicated time frames and small budgets, and I think we always penalize a little bit the last mile, which is dissemination of results. You mentioned that your research outputs are open source, open access. Thanks. And I was wondering regarding like local languages. Also support to local researchers or entities that could also help you disseminate in different contexts such type of research. Do you have any tips on how to make more with less?
Yeah. So no, you're absolutely right. We have the tendency to, especially when you look sometimes a bit more at academic research, and many people that do research also have an academic background, to say, okay, the manuscript has been published, it's been a long road, and we completely under-resource what we call policy and practice change or dissemination. But for us, it's actually one of the most important things, but it's also not easy. as you recognize. And this can happen on multiple levels. So research findings, bringing to the technical committees of WHO when it comes to medical research or epidemiological work that, for example, we do. But it can also mean that you, for example, look more at, who needs to implement the changes in the end. It's probably the public health agency in the country or the Ministry of Health, but we take them along in the research cycle. And one of the things that we've done quite frequently on a local level in the project is dissemination events. So one of the research team members actually goes back, a presentation is delivered to the MOH, and we try to see what we can do. But change doesn't come ever from a single piece of research. Science is a body of knowledge that is also generated by others, and sometimes it can take years before things actually get traction. Sometimes because the moon is in the right way, or there's a random opportunity. But it's also a lot of hard push that you have to do. And I think, we have a lot of room for improvement there as a global community of researchers, especially this day and age, because in the end, it's true. We are dealing with less and less resources, so we need to become smarter in our interventions. And that's not just, like I said, the technical parts of research. You can have all the tools to your availability, but a lot of it is also making sure that as scientists, we also push the political narrative to make the resources available, to challenge them on decisions not being taken, or sometimes people not wanting to see the data because the data actually counters certain political narratives. And that's a really important part of our work as well. That's also quite nice in MSF that we have the space to kind of work on that because of our independence. I previously also worked in WHO, and sometimes a bit more challenging. I also worked in the Red Cross, also sometimes a bit more challenging when you look at concept of neutrality. But I think we, as a global community, we can support each other in there. And we need to become much better in that, especially now.
And we're 60,000 staff working for MSF worldwide. 60,000, that's a lot. And so we find if we communicate well amongst ourselves with events like this, but also we have something in the UK, which we run every year, MSF Scientific Days, which is another forum for sharing. But there's also there's many, many events, essentially. So internally and then externally, then we push it forward, I think, as well, I hope. Allez, bon, I'm going to begin to round that one off and move on to the next topic. Please introduce yourself, Henri Michel. Yeah, this one is. There you go.
Okay, yeah. So my name is Henri Michel. I'm from the Luxembourg Institute of Science and Technology. This means that I'm based here and I'm with a team of researchers. And I am really intimidated because Heinrich, you said it all, and I don't know what to say.
Don't worry.
Okay. But I will try to give an example or some examples of what we do that allow really operationalization of research from Luxembourg. It's possible in link with the global questions that we have. The title is Climate and Environment, and well, we are working on infectious disease.
I'll stop you there because it's interesting to make the link between the climate, the environment, and our health. Can you start with that?
This is something we just discussed 2 days ago with my colleagues in microbiology to set the scene for an international meeting. And I just said, we're all talking about the climate and health, but the problem is not climate and health. It's climate, something else, and else. This means that climate is always interlinked and interplay with something that make it worse. So, for example, we are talking about mosquitoes that are bearing viruses coming to our region. We had the first recording of Aedes aegypti, which is an intertropical mosquito bearing chikungunya, and it was in France last year. And it was not expected before 2030. The problem is not climate change. The problem is transportation of goods are really important. In Luxembourg, we have one of the most important gas station in Berchem, and we observe the mosquito there because they are really coming with international transport. So international transport bring the mosquito, maybe in the near future, the virus with the mosquito. So the problem is this, and it's worsened by climate change. So climate change is always acting from our perspective. I'm an ecologist, so I'm looking at this really carefully. It's always worsening an impact. So globalization, intensification of transportation will bring new vectors and their viruses, and it's worsened with climate. biodiversity loss, which is for me the most important threat for humanity today, is worsened by climate change. So it's just to clarify, climate is coming as a worsening effect on this. And the last point, of course, is that we do not have to forget, even if we are focused as biologists on more animal, plants, viruses, and so on, that also poverty is one of the worsening, of course, actors in the propagation of infectious disease.
Okay, good. All right, so that's the macro. All right, so we're going to get practical now. I'm assuming most of you have a smartphone with you. It's the time to get your smartphone out because we're going to use something called Mentimeter. For those of you who not used Mentimeter before, it's like a quiz system. So the theory is that you take a photo, a scan of the QR code that you see projected here on the screen. If that's not possible because you don't have a QR scanner, you can go to www.menti.com and enter the 8-digit code you see at the bottom, 12289262. And for those online, you can take as well, absolutely. We hope that you join in as well online. And then there's going to be a series of questions that are going to pop up on your smartphone. We're going to go through them. And we'll start with, are we all ready? I'm looking to the responsible for Menti today. Who is it? It's Sonia. Okay, everybody cross their digital fingers. It's going to blow up. It's blowing up. It's working on the phone. Okay, and so I'll look at your phone, Radu, and then you can take it from there. So you should have a question on your phone which says, which population group is the most physiologically, can I read without glasses, vulnerable to health problems during extreme heat events? And then you can see some options: outdoor workers exposed to prolonged heat stress, elderly individuals and people with chronic cardiovascular or respiratory conditions, infants and young children, etc., etc. So you need to make a choice between those options that you see and then hit submit. And then we get some results here. So all go ahead and vote. And I'm going to sit next to Radu because he's doing it all correctly there. Good. We've taken some votes. And then for fun, I think we'll see whether does another question pop up immediately? No, we have to wait. And so we click through for the rest of it. And the idea really is to get you to again build on that link that we were talking about earlier, Henri Michel, between the climate, the environment, and our health, which you say is already, with the fact that we're living in a global world, we're transporting pathogens and vectors more than we were, but that's exacerbated indeed by climate change. We're seeing, for example, mosquitoes appear in places where they weren't appearing before. And they're taking with them the diseases that they transport, like malaria, like dengue, etc. That's what we're seeing.
Yes, exactly. And quicker than what we saw in the past.
And quicker than what we saw in the past. Good. So here we go. We've got the results behind. Amrish, I'm going to use you as an expert. Is that the correct answer? 24 people said elderly individuals, people with chronic cardiovascular or respiratory conditions. Amrish.
Well, if we look, for example, at heat in Europe, we know that elderly are really high risk. There's a lot of high quality research done, for example, in France for many years that see that every summer during the heat waves in Paris, there is what we call excess mortality. There's a lot of elderly people dying, and there's a lot of preventive measures that are being taken. How does it, for example, work in the countries that MSF works in? Well, we know that the risk groups are kind of universal. Yes, elderly people and young children have a tendency to suffer a lot from increased temperatures, especially when there is a lack of clean water, for example. So hydration is a big issue.
Henri Michel, are we seeing this in Luxembourg as well?
Yes, so especially I think the factor that is come into play is the water availability of good quality. We can even see, for example, if we are looking at an heat wave, so there will be also a pressure on the water resources. And there can be a disconnection in the quality of the water. And there are some mechanisms in Luxembourg. If the main lake in the north of the country is not really able to deliver the water quality, okay, we will activate some alternative sources, but these alternative sources work well with a normal precipitation, so not enough too much will lead to some problem. We have really locally in the past had this kind of problem, but we can think that we must anticipate that it can be really much more the whole country with a problem with severe heat wave, lower precipitation, lower water availability. So we must be prepared. It's really a question of preparedness.
And to bring it back to operational research, do you have an example, Amrish, to show us where we've done some operational research into this particular extreme heat events, heat stress, and links to?
Well, you know, specifically to heat events, what we see that everything that's related to climate change, changing weather patterns, is like Michelle said as well, an amplifier in terms of what we're already observing. So realistically, it means more of the same. So specifically to temperature change, one of the things that we have in MSF is a group that works, for example, with the International Federation of the Red Cross Climate Center on where can we expect in the long term temperatures to increase. So what we call risk mapping, for example. And unfortunately, that's the best we can do at the moment to kind of anticipate a little bit of like on a macro level where the risks are going to increase because the needs at the moment are already plentiful.
Yeah.
So,
but if I understand, a new unit has developed in Médecins Sans Frontières in the last 10 years, extreme weather events monitoring unit or something like that. I can't remember exactly what it's called, to do exactly that, to look where are we likely to have drought, flooding, hurricanes, etc., etc., to start to get ahead of the curve and start to prepare the teams on the ground to be able to manage that, work together with the Ministry of Health to empower them, launch operational research projects to strengthen, etc.
An example of a project that we've been engaged with, for example, with the university, well, the KIT, the Royal Institute of Tropics in Amsterdam, is to kind of actually work on, in case floods happen, for example, in Pakistan, where should we place our health facilities to ensure that access is maintained? So floods wash away access roads, but if you place them strategically into these areas, you kind of ensure that you reduce that risk of access roads being kind of like washed away and people still can find their way to the health facility. But it's incredibly complex because the predictions in this are not that accurate in the sense that we can exactly pinpoint where the risk is going to hit. So what we do, of course, is kind of make sure that our teams are better prepared to deal with more of the same or more of these climate-related events.
You work in South Sudan, that means learning how to canoe.
Yes, our colleague Iro is not here, but she has faced that a lot, the flooding in those areas, absolutely. And they come quick, and often you don't have time to anticipate in terms of when they're coming.
Yeah, maybe on this topic. So at the Luxembourg Institute of Science and Technology, I had the chance to witness the developments, and so just to talk about the time scale, to have upstream research a little bit disconnected to really an application which is operational on flood monitoring. The LIST team was one of the first to propose now services that are available worldwide on real-time monitoring of floods. It seems quite obvious. We have images from, for example, the satellites, and having all the different logarithm to treat this image and to say, yeah, at this place right now there is a road that is cut by a flood, is something that took 15 years. And it was really at the beginning, my colleagues were working on this after a PhD, and it was quite blue sky research. But today there is a company that has been created, open to any participants in the world, to really promote this online and real-time monitoring. And it's really an improvement, because if you have ambulance that must go in case of a flood, but at the same time an earthquake, it becomes crazy, and so it's allowed really to guide, for example, some emergency services to the right place. And it takes something like 15 years to be from research to operation. And it's really a nice example.
I remember 20 years ago, as a logistician in Congo, I just experienced the weather. But now we're putting weather stations in almost all MSF projects, and not particularly sophisticated ones, but basic precipitation, wind speed, temperature. And this information is helping this unit that I mentioned earlier. And so it makes us, we're far more of what the weather is like and what it might be like, and we prepare ourselves and accordingly, I think, absolutely.
And maybe really an important point, researchers are often really, I would say, biased toward high-tech applications. But what we need finally is as much as possible low-tech one. This means sometimes with one sensor, you have the information you need. With one device to collect water, for example, in the Mekong River, you will have a device, okay, what are we using is this cotton mask for removing makeup. You can find it in some supermarkets all over the world, rather than having a really specific high-tech device that allow you to capture, for example, viruses. I can talk about this. It's really what is a part of operation is also to see what are the resources. And in all cases, even in Luxembourg, low-tech, low-cost, perfect.
Absolutely. Are there any thoughts or questions on specifically this topic of heat and extreme heat events that you'd like to raise? Going once, going twice. Not then. Next question. Get ready to answer the next question. We're going to see whether we can figure it out. Oh, some of you have already answered it. Why might climate change lead to the spread of diseases into regions like Luxembourg that historically didn't experience them? We've given you some of the answer here, but it's interesting whether we can come up with some other ones. There's some options here. Changes in the land use, altering human-animal contact patterns. Urbanization, creating new ecological niche for vectors. Increased global travel, that was the one you touched on, Henri Michel. Accelerating pathogen introduction. And then indeed warmer temperatures, so exacerbated or enabled by climate change, enabling vectors being mosquitoes, etc., beetles, to survive and reproduce in new areas. Well, we've kind of given away the answers already, and so you've talked about this already, but perhaps you'd like to complete on Michel, specifically on Luxembourg. What are you seeing?
Yeah.
What kinds of emerging diseases are you seeing that you did not see before?
Yeah, so really the emergent problem that we are tackling currently with the Health Directorate and the Sanitary Inspection Services, especially, is the arrival of these mosquitoes that are really previously tropical species, bringing, I already told this for chikungunya, it can be dengue, it can be also West Nile, which
Mind us, because chikungunya and dengue and West Nile, these are perhaps things that I might, may not have heard of. And so what are these diseases? What do they mean practically?
Yeah, so these diseases are really typical vector-borne disease. Vector-borne means that in this case, these are mosquitoes that bite person, is taking a little bit of blood, which is contaminating another person. And there are really a range of different problems that can rise. It can be, of course, fever. It can be, in the case of chikungunya, there is really, the body is really altered in a way that people cannot work. And I think chikungunya means this in Madagascar language. So it's really things that are really not to take lightly. And the example of chikungunya is really, really important. In France, of course, travelers going to a part of France that are overseas were coming back with this. But now we know that the heat is enough. So the last answer is correct. The heat is enough so that the mosquitoes are there and they can survive the winter. So there is really the virus is in the population of mosquito and will bite in spring and some other people with propagating the illness.
And what about the clinicians in Luxembourg? Have they seen this disease before? Do they know what to do about it, how to treat it?
Yeah, so this is maybe a question for Vic that I see in the room also, and I thank him because I'm here thanks of the contact that they gave to MSF. So he can certainly answer better than I, because I'm not a med doctor.
So thanks. So yeah, we do see cases of dengue every year in travelers, not autochthonous cases of dengue, but travelers. Chikungunya is not that frequent, but it's pretty bad because it can give devastating polyarthritis, like, really destruction of the joints lasting for up to a year or more. Not frequent, but we do see them occasionally, and there are no specific treatments.
Yeah, and absolutely, because what's the reaction of the clinicians then? Are the clinicians complete panic and call the Tropical Institute, or are we beginning to see more education for Luxembourg-based clinicians to sensitize them to the presence of these new diseases?
Oh, GPs know about dengue and chikungunya. Yeah, well, West Nile was spoken of, that definitely less common, yeah, more unusual. Encephalitis cases are so much rarer. But dengue and chikungunya, yeah, the GPs know about that.
Because I remember from experience in Haiti, Amrish, you remember a few years ago, there was a cholera outbreak in Haiti, and cholera was very new as a disease to Haiti, not new to the world, of course, we see it in many, and that in itself was a huge challenge for the clinicians. And we ended up transporting a lot of clinicians from Congo to Haiti specifically to bring the knowledge. And so it's the knowledge transfer question that I'm trying to bring up over.
No, absolutely. I think in general, if you haven't seen a disease other than your textbooks, the first thing you need to recognize are the symptoms. And we see that also for vaccine preventable diseases, so diseases that we have very effective vaccines for. We see that because of vaccine skepticism, for example, in Europe, clinicians have, for example, not always been used, for example, to see measles on a very frequent basis. Now you see it more and more. And it means that, you need to go from the textbook definition. And unfortunate thing about really good textbooks is that they always show you the best picture you can imagine. But but manifestation of the disease has many degrees. Rash can look very different. And then you see that, national public health agencies, of course, directly upscale training and diversity and things like that on it. But indeed, like talking about cholera, it's also an issue for us. Like in many settings, like diphtheria is a disease, for example, that spreads really quickly. As well in populations, but to catch it without having a sophisticated laboratory that can diagnose the disease for you in reliable conditions, which in almost zero of the places that we work exists, or you get a result 5 to 7 days later, you have to recognize a plaque in the throat. And if you're not been used to see that on a frequent basis, it's very hard to see it. I worked in one of the largest diphtheria outbreaks in Bangladesh, in Cox's Bazar in 2018. And we really need to invest in that because you don't have a laboratory. So all you have to make sure that people received what we call the antitoxin is really the clinical interpretation. And it's really important. Maybe just one measure as well. Like I know, for example, in the Netherlands, not just going directly to the example of cholera, but due to the water shortages that you've referred to, last year we have seen outbreaks in drink water. And may I remind you that the Netherlands is one of the most high quality drinking water in the world, where, not small villages, but almost whole cities had to temporarily buy their drinking water in the supermarket. Is this directly linked to climate change? Maybe not directly, but it has a fact that we see more rainfall and that the water depletions are kind of shortening, but also that water is getting more polluted in general. It's not just bacteria that enter it. There's a lot of chemicals in the water, and it becomes more difficult to clean water after every cycle of usage as well.
So gone are the days when I used to come back from Africa and I would be like, everybody would see the thing crawling around underneath my skin and go, oh, exciting, exciting. And they'd call their other fellow clinicians to come in and take photos and have a look because it was unusual. And so now, because of this more global environment we're living in, because of the climate, etc., the change, it's becoming, everybody is being exposed to more and more. That's what you're seeing.
Yeah, exactly. I'm struck by the fact that there is really a low number of answers on urbanization. And I can give you an example which shows, I think, that interconnection between the different disciplines is important. There is a concept, I'm a water scientist, so I like to work on waterborne pathogens, but I'm also really like to see all the different measures that we can take to try to recover as much as water as we need, for example, during summer. And there is a concept in our community of water scientists, which is the sponge city. This means that when it's raining, retain the water as much as you can. You can have roofs that are vegetated. You can have all this device. But on the other hand, I'm working on the invasion of mosquitoes, and you know where mosquitoes are breeding. They are breeding in small water collection that are eating really rapidly. And when you have vegetated roofs, you will have this small water collection with a black surface. It will eat rapidly. And so we have a kind of collision between two concepts. One trying to solve the problem of the water availability. And on the other hand, the other one is to stop the progression and the invasion by the mosquitoes. And urbanization in Luxembourg is not a small thing, as you all know. So there are more and more of this building with flat roofs. And there is finally difficulties to make operational the knowledge that we have with the different administrations to find the correct way to on one hand promote the water retention, but on the other hand want the people that pay attention that this is not a nest, so to say, or a breeding place for mosquitoes. And there, the interconnection between different administrations that were not, for example, working together before. So Health Directorate with environment, it's not so natural in the past, but now with the globalization of problems and climate change on one hand, but also health problem linked to this must also be consolidated. And in Luxembourg, it's a good example that now they work hand in hand. But urbanization is also a point.
Because Rado was explaining to me earlier the fact that the population of Luxembourg is around the 750,000, aiming for 1 million. So there's a big investment to go to, and so that with that comes urbanization, with that comes construction.
Exactly.
But bringing it back to operational research, that's I think every operational research project is different, and everyone involves different people, partners working together. And it's always an opportunity in operational research question to build new partnerships between people. And here it's very interesting to see urban planning and public health coming together. And there's an operational research opportunity if there ever was one. Flat roofs.
I think for us, I am always kind of saying like research is a good vehicle in terms of building partnerships in many ways. And those partnerships then benefit our operations in general as well. And we need to become a bit more appreciative of the fact that, especially now, these partnerships are important because we all deal with resource scarcity. We all sometimes have to deal with political administrations that have defunded academia largely. We're still lucky in MSF that we have the independence to do that research, but we can't do high quality research just by ourselves. We need, for example, partners with strong lab capacity, or partners that have a good understanding of how to collect samples in the environment in an affordable way, instead of using a sample collector that already costs $200, because that's out of the question for us. And it's a really important part of it. And I think the urbanization is not just an issue for countries in Europe. It's in humanitarian contexts are also more often urban areas, because development has not been standing still. And one of our biggest fears are indeed these vector-borne diseases. We've seen huge outbreaks of dengue, which is very hard to treat in general. It's very hard to diagnose, but over the years it's become worse. We worked in one of the biggest outbreaks in Asia, again in Bangladesh, with also Institut Pasteur. And we've seen how challenging it was, not just to treat patients, which can overwhelm your hospital because everybody comes with symptoms. Well, factually, the only thing you can do is symptom management, but you don't have resources, which means that other diseases and people with other symptoms don't have the entrance pathway into your hospital anymore. And the other part is the environmental part. In a refugee camp where you have small bodies of water everywhere, and it's an impossible task to remove those, because you can do big community campaigns that we did, but a month later, it's the same problem. And these Aedes mosquitoes that Michelle was talking about are very difficult to combat, because they don't care about bed nets so much, because their biting behavior is actually almost the whole day. So before you're under a bed net. Insecticides, well, they're a bit stronger and resistant against most of the insecticides that we use. But also when they lay eggs in the water, when the water body runs dry, the eggs, they just stay. And as soon as water comes back again, that's when they hatch. And it can be a year later. And that's your import and export problem of tires, for example, that come from other countries. Or in the past, it was bamboo shoots that you can buy here in a gardening center, and that import these type of diseases with them. Maybe one last point, Robin, to make is that how do we know that diseases are present in certain areas? Because here, obviously, you have good surveillance systems, as we call it, which means when a clinician sees something, they take a sample, it goes to the laboratory can confirm it, and then we kind of have an idea of how many patients you have and how a disease is kind of developing in a country. In many of the contexts that we work in, we don't have that. So one of the things that we also try to do is, where we have laboratory capacity, is make sure that the data we collect in what we call black box areas, where we have no idea what is happening with the disease or what's happening for example, antimicrobial resistance, so which antibiotic you should use, that it's fed in global systems as well. So we get a better idea of understanding what's happening. And again, a good example is dengue. A colleague of us, Iro, she worked in South Sudan, and they had a lot of patients with what we call fever of unknown origin. So they have fever, So clearly they are probably sick. They probably have a pathogen, but we can't diagnose it. And she asked for some rapid diagnostic tests, not for malaria, but for dengue. And indeed, it was a dengue outbreak happening, which hasn't been that frequently recorded, but the mosquitoes are there. When the mosquitoes are there, the disease will be there as well, in low numbers, but very quickly in large numbers as well globally.
From Luxembourg, do you have any examples?
I can give an example on the question of how many patients are there or how many people infected. There are two cases where we had the opportunity to develop once again on the longer term. So we were in 2020, we were working for 15 years on the possibility to use the wastewater as an indicator of the people that are infected by viruses. It was noroviruses, so essentially gastrointestinal disease. And the problem is that the funding agency says, no way, it's not interesting. But we continue to do this for 15 years and accumulating some interesting results. And then COVID-19 came, and in some months we were operational and just making a kind of a press conference. And we were the last in the row to present something exotic. We can maybe have COVID-19 detection in wastewater. And from press conference to the other, we were more and more in the forefront of the audience, and the minister at the time of health called us directly and say there's something interesting going on there. So to be operational in 15 years, and now we can see really low levels of infectious people in a population. Of course, we don't know who it is. But in the wastewater, you can do this, and you can do this in water. We are doing this now in Mekong River, for example. In another case where we are reaching the eradication of a endemic disease, for example, for schistosoma, Mekongi. It's really an endemic in the South Mekong. There are still some cases. It's really difficult to know exactly how many people are infected, but to prove that we have eradication, we must have an indirect way. And we look in the Mekong water if we can find the genetic material of this parasite that has been excreted by people and coming in the river. So these are now also an interplay of environmentalists, environmental microbiologists, helping what was not thought years ago, epidemiologists to give an information. The only exception was poliovirus, but yeah, it's really coming. And once again, it can take 15 years so to be operational. But when it's operational, it's really well working.
Yeah, no, it's super interesting, because indeed sometimes the tools are already there, but there's not a lot of traction. During the pandemic, a lot gets accelerated. I worked, for example, also on wastewater surveillance for enteroviruses, for polio, for example, which we did also in Europe.
Polio
and that's one of the, the fundaments at the time, because there was a big, push for eradication. But then these technologies and approaches can be applied to other diseases as well. And it's very true. It doesn't tell you exactly who is it, but it tells you something. Is it circulating? Is it increasing? Is it decreasing? Is it remaining stable? What are the different species that we see, for example? So it's super useful technologies.
Always good to leverage a good catastrophe, like in the UK at the moment, the meningitis outbreak, which is unfortunately has cost the lives of 2 young people. And so that's going to be a good, raise the awareness around that as well. But it's a shame that somebody has to die before we do something about it. But I guess you face this reality as well. People who fund your research feel that if there's no obvious value now in the short term, then it's very hard to get traction. It's very hard to get interest. But I hope you have some kind of independent funding source where you can actually push through some of what you see as valuable research in the long term.
Yeah. And the problem of the lowest or the lower resources for research today, it's less and less from years, at least in Europe, is that the funding agency requests that you can prove that it will be efficient, but it can be efficient in some circumstances, for example, an epidemic or a pandemic. And of course, you don't have the opportunity to prove it. So it's a little bit also chicken and egg, but to be prepared, we must have some funds. And we have now for research to move to other sources, just like, for example, the Health Directorate, because they are interested in preparedness. And research funders are not risk takers.
Yeah.
So this is where we are. And so we can find small amounts. And for example, good news for Luxembourg is the National Fund for Research has also thought about a LuxOR call, which is find partners in the target countries of Luxembourg in terms of international cooperation if they have a problem that can be solved by research, but really in an operational way. And this is why we are today in the Mekong River together with Institut Pasteur in Laos, thanks to but the amounts there, they are really so minute compared to industry applications.
Yes, of
Once
course,
again,
yeah,
I'd
yeah.
say we all know this.
Several URLs or several institutes are being mentioned while we're having this discussion. Please drop them all in the chat, and so people can find them afterwards. And indeed, this session is being recorded. Somebody asked that question in the chat too, and so we can share this information out afterwards. Good. I'm going to move on to the next question. So for those, some of you may have answered it already, which says, why might climate change lead to the, oh, here we go. Which of the following best describes a climate-sensitive disease? A disease whose incidence varies with environmental conditions, but is primarily socially determined. A disease whose transmission or severity is influenced by environmental factors like temperature or rainfall. A disease that emerges only under extreme climate events. Or finally, a disease that is restricted to specific geographic climate zones. This is hard. Who wrote this questionnaire?
Really tough.
Here we go. But obviously, it's one of these things where it's all right in a way, and it's just a way of introducing the question. And let's see, 17, 19, the second one seems to be getting the most votes, the most liked. Henri Michel, would you share your thoughts on this over?
Yeah. So there is a little bit of truth in every, I think, and it's the most obvious is the answer that has been given. But yeah, restricted to some zones, I would not really say. This is really mostly the change, but not only in the extreme events. It's also really the basic regime. It's not because we have really hot summers that we have mosquitoes. It's because we have mild winter, which is an evolution which is really, I would say, smooth. It's not really because we have extreme event, for example, for mosquitoes. It's rather the general conditions. So we don't have to just look at what we see in the newspaper or in the news with floods and drought. It's rather that globally, the basic climate regime is changing. So it's a disease climate sensitive. I mean, for me, essentially that it will be promoted in some areas due to shift, but there can be a small shift. It's not mandatory, really large things. And it's continuous process. But as I said before, we had some models from the GIEC, for example, to say, okay, projection of climate in some, but it's quicker for infectious disease. This means that it's not only the climate, it's other things.
And if I can ask you to now look ahead for Luxembourg and the context, what are you thinking of 5, 10, 15 years down the line? Where do you see the new challenges coming?
This year, next year, we are really in the middle of having things that are, well, we mentioned the mosquitoes, but there will be, climate change will really impact our resources. And once again, climate change will lower our water availability because on the quantity, but also on the quality. And the problem is, once again, the interplay of the fact that we mentioned this, the population of Luxembourg is increasing, the density of population is increasing. So it's really for the 5 next year, we have really large challenges that is due to economic development of Luxembourg, with the overarching question of climate change, but also, as noted before, the change in the land use and so on. And so it's not an horizon in 20 years. I think it's really ongoing, if I understood correctly your point.
Yeah. And then talking very specifically of the population, because for Médecins Sans Frontières, we have a vast array of staff whose role is exclusively to engage with the local population, health promotion, discussing all of these things. So there's constant feedback loops, and we fully understand, well, we do our best to understand what's going on in the local population. But I'm not sure that you have that in Luxembourg. And so how do you build these feedback loops for the community? How do you engage with the community? How do you mobilize the community around an issue like flat roofs being nests for, et cetera, et cetera?
Yeah, so there have been some initiative from the Ministry of Environment who were really interesting. So trying to find the connections with the with the citizen in general. So it can be associations, they are quite active. There is the Cell, for example, so promoting sustainability, and have a reflection with them. So we had really, the way to do is to build knowledge of each other first, so connection, and I'm sure you said it before, so this means having the connection and then having the capacity building all together with the different views. So the people say, for example, we would like to have places where there are, we call this water trees. This means artificial trees that are just increasing the water in the air during the summer. And then we have also around the table people that are epidemiologists to say, yeah, but if you have this, you just take back the water. There are pigeons, there are poo from pigeons, and there are Campylobacter, and so you are promoting also the spray of it. So we have built this, but what we see is that it's easy really to promote and have good ideas and consolidate groups of already concerned people that are already thinking of it.
It's getting
And then after the next step is to have really the general public, the citizen, and there I think it's still really difficult.
Yeah, absolutely. Good. All right. I'm just keeping a peek on time, and we're having some fun and games here. Do you want to show the videos for the next session? I think, yeah. So we can begin to. We've got time for one more question for Henri Michel on this specifically, this issue of climate, environment, and health. If there's a question from the floor, please, sir. Share your question.
My name is Federico. I'm really curious about the topic that you were mentioning about the mosquitoes. Especially if you're a researcher, have you considered, I don't know, trying to create a device or something that could exterminate them, especially for the environment of Luxembourg, more than trying to educate? Maybe you have an idea on how to create a device, like something like the floaties of Hamelin that can attract the mosquitoes and we can get rid of them.
So working with the MSF, we do a lot of indoor residual spraying, which is people dressed up in very scary masks and full personal protective equipment going around with a fogging machine, putting insecticidal spray all over the walls. Do you do this, or is there some kind of magic bullet for these mosquitoes, or are we in trouble here?
So there are two, so to say, rather mitigation measures that we can take. The first thing is that acting in Luxembourg means that when we detect a positive, normally we have the obligation to act. If it's Aedes aegypti, it's written in the European agreement. So we have to do something. And there have been a lengthy discussion on what we can use. So we detect where is it, and we applied a insecticide which is based on the bacteria that kills specifically the mosquito. So it's a kind of how to say, gentle treatment of the water bodies. So we are not fumigating, we are not doing this. There is another way to do this when this is not a low amount of mosquitoes. So what I said is already practical and made. If we have Egypti, we must act. It's an obligation. But if you have really infestations, there is this also biological treatment that consists of having raised a large number. When I say large number, it's billions of mosquitoes of interest, males. You sterilize them and you released it in the environment. This means that what you are doing is diluting the effective reproduction of females. So there are factories that are producing Aedes, males specifically. They are sterilized by rays, and you just go, you just go, and this is really effective because this is a dilution effect. The question is that I am an ecologist and I work on alien invasive species, and this is not something I like really much. But these are the two ways. The first one is effective in Luxembourg. We cannot afford here, because the population is not prepared, but is it prepared somewhere, to have people coming with a full combination and fumigating. Otherwise, it will be, but maybe in 10 years, it will be an habit. You know, the surgical mask was something weird in Luxembourg in 2020, but today people are coming to work with it. So it can change.
It can change. There you go. Thanks very much for the question. We'd like we're very privileged with Médecins Sans Frontières to work in many different parts of the world. And one of the things we like to do regularly is hear voices from the operations, from field, as we see. And we've got a couple of short videos with people speaking on this topic, which we'd like to play now. So go ahead, Sonia. Everybody cross their fingers.
Zany dia zazabitika natety dia lehibe taketo fa tagnatin'ny fahabitana ma zany dia efa sisa hoe cyclone mafy fa tagnatin'ny fahalebiazana dia hita hoe mafy satria tamin'ny Basiray tena ripaka sisy ranoringana se na tragno na fiarahambolena na ino biby fompy aza dia lasa matimaty foana dia hitako zany hitako hoe mafy.
So that was Madagascar. Amrish, is there anything you'd like to complete on specifically the context of Madagascar before we show the other video?
Well, I mean, there's many countries such as Madagascar which are incredibly climate sensitive. And if you have a weather event, a severe weather event once, that's one thing. But if you have them seasonally, they're affecting your livelihood, they're affecting the systems. This is where you make very vulnerable ground for any type of infectious disease to come in. We've seen that, for example, Madagascar is also known for routine plague outbreaks where there's a climate angle because it's kind of related to rodents. And that's sometimes something I don't think we realize sufficiently enough, that climate change and environmental degradation is a system level event. There's a few things that we can very clearly think of how it's going to impact, but many things in the long term that we don't foresee correctly because people will be touched in their livelihood. Governments will have trouble funding their healthcare system. So you really see the decline. And there's been some excellent research done, for example, in the early conflict of Syria. How did it got escalating? And what they did see is that because of the droughts and the temperatures increasing, people actually move more to the capital cities, which pressured the capital cities in many ways, which led to friction between different populaces in the city, which kind of was an amplifying element to the conflict and war and destabilization. So I'm just trying to sketch the macro perspective for you. We've been talking a lot about mosquitoes and obviously vector-borne diseases we're very worried about, but the impact is so fast and very difficult to forecast how it's exactly going to play out.
Yeah. Hello, thanks so much. Have a look at the second video, please, Sonia.
Hi, this is Srijit, medical coordinator from MSF OCB, Bangladesh Mission. Thank you for providing me with the opportunity to speak about the challenges of climate change and its impact on the health and well-being of over 1 million Rohingya population living in Cox's Bazar. Currently, we are witnessing an alarming escalation in weather-related events, particularly cyclones, which are becoming more frequent and severe due to the changing weather. For example, this year we came across 2 cyclones instead of the usual pattern of 1 cyclone per year. These cyclones are not just meteorological phenomena, they are public health crises in the making. The aftermath of such storms leaves behind more than just physical destruction. It creates a breeding ground for waterborne and vector-borne diseases. The Rohingya, already a vulnerable population due to the living conditions and systematic exclusion, are facing increased risk of cholera, hepatitis E, and dengue and other diseases due to contaminated water sources and compromised sanitation facilities. Moreover, the shelters that provide refuge to this population are not built to withstand such climate events. During the last cyclone, which occurred just a couple of weeks back, destroyed almost 38,000 shelters and it affected 500,000 people living in the camps. The mental health impact of these events cannot be overstated as well. The constant threat of disaster and the destruction of their shelters contribute to a sense of uncertainty and trauma. In conclusion, the intersection of climate change and public health is a reality for the Rohingya in Cox's Bazar. The changing weather pattern threatens to undo the progress we have been made in improving the health of our beneficiaries. Thank you.
Marista touched on mental health specifically, because I think that's definitely a growing theme within the MSF medical community. Please.
Yeah, I think like linking to Shreet's example from Bangladesh, where I also worked for 1.5 years. So MSF has two operational projects, actually one. One is, of course, in one of the biggest refugee camps in the world in Cox's Bazar, with 1.2 Rohingya that had fled in 2017, largely in 2017, big exodus following a genocide existing in Myanmar, that moved to Cox's Bazar, an area that is incredibly climate sensitive and environmental sensitive. And all of a sudden, there was a huge amount of people that had to be settled there. Now, every year during their strong monsoon season, and Bangladesh in general is a very sensitive area to that, about 6,000 households are washed away. Now the infrastructure is a bit better, but you still look around 3,500 people that experience that year after year after year. And you can imagine what that does with a person that is already in a refugee camp where they're not allowed to work formally, and your whole livelihood is consistently being affected. What perspective does that sketch for your future? What does that with you? What does that do with children that are also not allowed to formally take, official education, to say so? And this happens in many spots in the world. Your livelihood, your security is affected. I mean, we all go back to home, but there you cannot think in an annual cycle ahead. And it, of course, has a lot of impact. I'm not a mental health referent, but I think anyone can relate to how this affects you as an individual, as a family, as a community. And that's also one of the worrying aspects, I think, related to climate change. What I said, the impact is so fast, fast as in big, not that it immediately happens. But it's for us also very difficult to forecast what it actually means in our own operational adaptation. I often say it will mean much more of the same. So we need to become better in doing much more of the same with the limited resources that we have.
All right, thanks so much. Henri Michel, any final words before we close on this session?
No, I think that the challenges are really, really big in front of us. But I think that from our field, it's really so we have identified the things, but there is a last one, which is uncertainty. This means really we are sometimes reaching a border that we don't know, we cannot see, and it can really be something completely different that we have not foreseen. And this is for us trying to see a little bit in the fog what is really in front, because we have many knowns, but we still have unknown, and this is really something scary in a way.
Round of applause. Thanks so much indeed. And do join us for this time. So don't worry, there's a coffee break coming soon, but we'll get one more session. And if you're really thirsty in the meantime, there's water here. There's water knocking around at the back as well. And I'd like to invite a few more people up to stage as well here. Radu, Silvia, Umberto, please. There we go. So we can start with some basic introductions. Please, could you say who you are and what do you do? And the way it works, yep, go ahead.
I think it works. Hi, everyone. Thank you for coming and joining us. My name is Sylvia Lim, and I'm an operational research advisor. So my background is in public health and epidemiology. I'm also trained a little bit as an anthropologist. Thank you.
I jumped on the word advisor. So you don't perform the operational research yourself. You advise people to do it?
Yes, in most cases, but my job is it's a little bit of a mix. In terms of doing the actual research and the advising. So my work consists of not only working with colleagues in the field to maybe say prepare protocols for research, for example, or to maybe mentor them a little bit on how to collect data, what are good data systems to use. But sometimes there are also research projects where I get a little bit more hands-on as well. Yeah. So it depends.
Thanks so much, indeed. So that touches on the question that came earlier about, reinforcing the quality and the ethical side of the research we do. And your based here in Luxembourg, but I assume you travel regularly to our different projects as well to meet people on the ground.
Yes, I do. I'm based most of the time here in Luxembourg, and it depends on the specific project itself. So, for example, the last field visit I took was to Nigeria, where we basically because of my background also, I was also an epidemiology advisor before, and there was a cholera outbreak. So I was helping one of the projects work the outbreak, and then after that, I go to another project to help them put together a protocol for research.
Super
So
clear.
that is kind of like an example of what my work
Bit of
is
both.
like. Yeah.
Lovely, thanks very much. And Umberto, in fact, it's the first time I realized you're Dr. Umberto. For a decade, I've known you as Umberto.
I am. From now on, Robin.
I have to change my way of addressing.
Good afternoon, everybody. I hope that you still have a little bit of energies for the second topic of today, and I'm very glad to be here with you. My name is Umberto Pellecan, and I am actually a doctor, but I'm not a medical doctor. I'm a social scientist. I'm a doctor in anthropology. So it was mentioned before, because I think that you have this question in mind, Robin, what is anthropology? Anthropology is the study of the sociocultural diversity of the human beings, and this kind of science is applied as operational research in LuxOR and MSF as a way to understand the community dynamics towards certain diseases, morbidities, risks, etc. It was mentioned before by Amrish, some practical example. My role is like the role of my colleague Silvia, so I coordinate and supervise operational research within the domain of medical anthropology specifically, often in coordination with my colleagues from different domains.
Radu, we've just spent 2 hours in the car together. I've been enjoying the journey. Let me show you where the microphone is. And by the way, Umberto, when you hold it close to your mouth there, it's very loud.
Yes,
Yeah,
now
okay.
it's working. Let's go.
Go for it. Please,
Yes,
who are you?
hello, everybody. So I'm also not a real doctor.
Ah.
Just a philosophy doctor, let's say, like to put it in the English word. So I'm more expertise in environmental health, by the way, as a background, and I have public health expertise as well. So I'm currently heading the Department of Health Protection within the Luxembourg Health Directorate. And just to give you a brief overview of the health protection department, because they are the departments within the health directorate that have been created quite recently, let's say, so a few years only. So there we gathered several divisions or services inside. So there is one service of environmental health. There is another division of sanitary inspection or health inspections, which is working a lot on these infectious diseases. So COVID was a very tough period for them. I was not there, so it was that's why I say for them. They are my colleagues now. And then we have also the part of radio protection that we are having in. And lastly, but not the least, it's the clinical service for the health of the migrants. That's why I'm here as well.
Can you unpack that clinical service that you provide to migrants here in Luxembourg? Can you give us an idea of the kind of patients that you're seeing, the volume, their backgrounds, the kind of pathologies you're seeing, the work that you do with them? Just give us a picture of what a day in a clinic is like. Over.
So before reaching to that, so just to give you a little bit on the context, because in Luxembourg, the philosophy is that for every person, whether it's migrant or it's staying in the country, we want to have the same level of healthcare. So starting from that idea, when a person is requesting for international protection, because that starts with our colleagues, which are from the Internal Affairs Ministry, that they are dealing with that, they are taken in one of these structures that already exists, where they offer housing, and also there is this administrative follow-up, but there is a compulsory checkup, medical checkup, which is done by us within the 6 weeks after registration. So there we have 2 main duties. First, to identify whether there are any diseases, any infectious diseases mainly. That's one of the duties. And it goes both ways, whether to protect the country, but also goes on the other side we are really keen in terms of vaccination and so on, that they are well vaccinated. We propose, we cannot force because we propose. Also, whether or not they will stay, that we are doing our part, our share, and saying even if they go back, they are vaccinated, they are up to date with everything. So that's one of the things. When they are coming, they have a kind of full checkup. We also take care of the diseases that are, like diabetes, whatever other diseases they have. We take that in charge. We have a network also with other colleagues to give them help, like from the CHL, which is the main hospital one of the main hospitals, the first one in Luxembourg. Now there are 4. We work with them with the infectious disease there as well. So if it's a follow-up for tuberculosis, HIV, whatever treatments are given as well.
To touch specifically on that, when we were discussing earlier, I found it very interesting that you provide the counseling that's very important when you're doing HIV testing, because to discover one is HIV positive is a big deal. And then you make an effort as well with around the languages, and you have translators, and so can you talk around that a little bit, that the kind of the full picture of...
So how we are organized, really, we are trying to give the best care possible. So we have also at least 2 persons for languages to translate, that will be together with the person that asks for international protection. So we try really to make sure that they understand, and that's the same with our colleagues from the national office. I like more the French term, national registration office. It's in English, but in French is Office National de l'Accueil, which accueil is much better than just registration. So there it's also they try to teach them the administrative pathway, and to be there. They have also how it's called, social assistants that are available for the migrant population. And in our case, when they come to our clinical service, it's a clinical service like any other in the country. So you just come, they have appointments, they will be seen by a general practitioner. We will have to see whether the vaccinations are necessary. We will propose all the range of vaccinations, hepatitis and so on, flu whenever it's the season. And then also we can guide them if they need some specialized treatment as well towards other practitioners within the country. And they have also financial support together with our colleagues, because they don't have to pay for any of those, meaning that we have a system with a kind of, we call pink cards, where they go around, and they take also from the pharmacy that they can get all the drugs that they need. Certainly is the same list as for the national one, so one that it's reimbursed by the national case, they can get as well as for any other person in the country. So it's free of charge.
It seems to me that on the journey that people take when they're migrating from Northern Africa, Pakistan, Afghanistan, you were saying that these are the kinds of countries that you see people coming from. If you look at the countries that they must travel through on their way, and they're going to England, it seems that Luxembourg is a great place to stop off for your healthcare. I mean,
I think there is a kind of, let's call it also, we know, especially in the winter season, we have, but it's limited, to be honest. We have this kind of healthcare tourism, but it's quite limited. To be honest, the large majority, it's a passing through, but I think it's our duty to take care of their health. So on the other hand, it's not up to us to judge exactly why they are doing that and how they are doing that. For us, is really to give the right help in this sense.
But from an MSF perspective, it's wonderful to hear you say that you feel it's your duty, because many governments don't. And that's something we're going to touch on, I think, later in the session. Good. Well, thank you. Welcome, all 3 of you. As usual, we're going to get you involved as well in the audience. And so it's time to get your Menti quizzes out as well. We're going to give you some questions. So once again, if you've just joined us and you're not aware of what this is, Mentimeter is a little quiz thingamajig. You scan the QR code or go to menti.com and you enter the code. And questions will pop up. And then good luck. Everybody wish luck to Sonia, who's mucking around without even a mouse. Sonia, you're very brave. I'd at least given myself a mouse. And we get the first question, which is coming up now. And I'm looking at Amrish to see whether the first question is working on his phone. Is it working on your phone? Okay. Okay, so the first question is, what do you think are the reasons for people leaving a place? So this is the drivers behind the reason to migrate in the first place. Because there is no work, because there's no food, lack of healthcare, education, natural disasters such as flooding or conflict and violence. And once again, you can see that there's no right answer in this, but it's just interesting to see a perception online and in the room of what we feel the drivers are behind this. Good. So Umberto, I'll start while everybody's noodling away with the questions. What do you think the drivers are? And you don't look at the answers. What have you experienced? And can you make a link, please, with operational research? Has MSF done any operational research about this? You talked about anthropology, you talked about communities.
Yeah.
Tell us what you think.
Yeah, maybe I will start by saying that talking about migration, it's a bit of a strange topic in connection to humanitarian context and health, because migration per se is not a health condition. Migrants per se, they don't bring disease, or they're not disease, and the structural facts movement that is actually universal in the human history of moving from one place to another is not necessarily a disease in itself. It's the conditions where this population move and where this population fall into, and so the conditions for which they live that create health conditions, morbidities, as we say, on their physical and mental health. Actually, the answers of these questions are all correct to a certain extent. The lack of opportunities, so the economical marginalization of the countries of origins of migrants and asylum seekers due to the history of colonialism, for example, or for the current contemporary exploitation of resource, is a driver of escape, of course, but this sometimes compounds actually with the topic that we touched before, climate change and environmental degradation. An example of that is the increased desertification around the Sahel area that actually is connected to the exploitation of the land from big corporation, the so-called phenomenon of the land grabbing that pushes actual population to leave and to move. And of course, is the title of our session, is the connection between migration and conflict, which is one of, let's say, the most intuitive, let's say.
Can I touch on that briefly? Rado, from your perspective, because we were discussing on the way in about different countries and the impact of conflict and therefore the impact of the people that you see in Luxembourg in your clinic. Can you just...
Yes, so generally it's very much related. There are some delays in between the time that the conflict is starting to be quite long and the time that they arrive. Might be from different reasons, because the journey is not just you take a plane and you come here. And like you were saying, I like very much to see, because we talk about the health, but the health issues is not the trigger of their living. It's something that happens along the way, whether it is an infectious disease or whether it is vulnerabilities in a large sense, psychological, psychiatrical, because the travel is not easy. So there we have also an interest in the identifying vulnerabilities. That's what we do also in the service. Also, in order to provide the right care, and the most complicated is really for the psychological and psychiatrical, and also you have this part of, due to their travel, you have this part of addictions, which are quite often arriving as well. So there we have a psychologist in our team as well, trying to do a first screening in order to identify this vulnerability, psychological addictions. And then we have a network of associations in Luxembourg that are very active, that are receiving also money from the Ministry of Health in order to treat these people. Because You know, when they come to us, it's in this period of 3 months, which is the obligation to come, because after 3 months, if they stay, they will have exactly the same health care like anybody else. So they will have the full rights like anybody else. The thing is that in these 3 months, if it's a psychological issue, you cannot treat that in 3 months. Generally, you need a longer follow-up. So with these associations, we try to give this longer follow-up in order to take them into account for a more holistic approach, you know, for their health.
Maybe just quickly on your question, how this interlinks with operational research, we will see it in the session today. But exactly because of the condition of migrants are actually multi-phased with mental consequences and physical consequences due to certain social and political conditions. Actually, most of the operational research that MSF and LuxOR carries on tackles with different methodologies, not only the consequences on health of the conditions, but also different models of care. Now you were exactly mentioning the aspect of the mental health. Imagine the difficulty that you have in a context that is stable as the health sector in Luxembourg. Imagine to have the same assistance for psychiatric patients that are on the move across different countries that have different systems of health and also different social conditions.
Ellie, we're going to go for another question for fun. Here we go. This time it's a word cloud. So what do you think, and you have to type in words, are the reasons for people coming to a new place? Go. Work, absolutely. Safety, absolutely. Peace, money linked to work. Quality of life. Accessibility, I'm not sure accessible to what, but living conditions, a future. Sylvie, share some thoughts about what you see. Have you done any work on operational research specifically on conflict and migration?
Yeah, okay. No, this is a very good question because MSF, as a medical humanitarian organization that works globally, we are present in a lot of these different circumstances. And wherever we do work and wherever that we're present, there is also this opportunity for us to do operational research. So, so for example, one of the research that we are doing right now that is maybe closely related to conflict was what Amrish had touched on. It's basically documenting injuries that we see in Gaza of the patients that we treat in the hospital, for example. And then after that, a lot of our, for people who are on the move as well, you know, you've talked about the very dangerous journeys that people go through. And for example, people would board these boats that cross the Mediterranean. People would walk for kilometers, like through mountains and forests, like in Eastern Europe. So these are, in these kinds of cases, like as MSF, we also have launched, for example, search and rescue missions. And also we've had healthcare workers actually going into the forest to provide care. So this was actually one of the examples that we have documented in Poland, trying to understand a little bit and trying to kind of like reach a little bit, like, you know, the people who are trapped between these areas, between borders. And one of the things that we are trying to also explore and trying to document, and document being the key word here, is how would these kinds of like migration health policies that countries actually take really affect healthcare and the health of the people, or the health of the people on the move at the end. So this is one of the key things that we would do.
And if you look at, for example, the way that we've adapted our operational response as Médecins Sans Frontières to forced migration or displacement, and you look around the idea of internally displaced people camps and things like, have we seen more people moving as MSF over time, and have we adapted the way that we work with patients in IDP, intentionally displaced persons camps?
Yes, I would say we have, and given like, as you know, Umberto was saying, the different types of reasons why people are moving from one place to another. You know, and as everyone there are more and more conflicts that seem to be going on in the world right now. And every time when that happens, I think people move for safety reasons, and they would end up in
It's
one
the
of these
number one
horrible-
word you see in the middle of this
Exactly.
word cloud. Absolutely,
Yeah,
safety.
yeah,
And
for
for being
safety.
a very large one as well, very interestingly too. Yeah.
Yeah, so kind of going back to the question as well. So I do think that we are seeing a lot, and I think internally, as you know, we are also doing a lot of responses, and in these places, we respond in many different ways. I mean, it could be from like the distribution of food, of blanket, hygiene kits, making sure that people have clean water, functional latrines. We also provide vaccinations. And we also, do basic health services, including sexual and reproductive health. And I also wanted to go back to what you were saying about mental health care earlier. But one of the facets of the work that we do, and one of the ways that through research we are trying to also understand how we can do better, is the provision of care that we normally don't outside the scope of responding to infectious diseases. So for example, there's the mental health care aspect of it, but we also have programs that reaches out to people who have experienced sexual violence, people who have experienced torture. And so, and this is not very easy. And this is also, like you said, the continuum of care. When you see these people, they're only in one place at a certain time. So when they move along the way, I mean, how do you actually reach out to them and make sure that they continue to get the care that they need? And it's very complicated. It's not only like you give them care for one time and that's it, but you're talking about psychological care, potentially some medication. People who's undergone very severe torture sometimes require rehabilitation. And very intense medical needs. So this is also one of the ways where we try to look into how we can, figure out what are some of the best models of care, like Umberto say, that would work. Yeah.
Or even if we just look at your healthcare records, in Belgium, my healthcare records are on a system. It's online. I can access it from anywhere in the world, but I mean, it's specifically around Belgium. When you're moving through multiple different countries, multiple different health systems, etc., I'm assuming, Radu, when you see patients come in, they don't necessarily have access to their previous healthcare records. Can you talk a little bit about that?
Yeah, that's one of the main challenge because, in terms of, for instance, vaccination, it's always a dilemma whether do we do vaccination, do we believe the patient, which passed through different stages, maybe get vaccinated. But yeah, you have risk benefits, and then we do an evaluation and we try to see, and we prefer to give them the opportunity to have this vaccination. But it's very tricky. General, for instance, if I take tetanus, for instance, that we do it, if there is no written proof, we just do it because we know that the risk of over vaccinations are zero. So you have these kind of things that we really offer, but it's challenging because we almost never have a full record of the past, and generally we have quite long discussions with the migrants in order to understand also their past, where they've been through, the passage, the countries that they are coming from, or they passed through. It's important in terms of also infectious disease as well, to determine whether we need to be more clear whether they need to do something, whether tuberculosis is there or not, and all these kind of things. So that's really in the anamnesis. It's one of the steps that is very important.
There seems like a gap in the market because MSF teams will see somebody in South Sudan, then again in Egypt, then again in Libya, then again in Greece, then again in et cetera, et cetera, et cetera. And to be able to join the dots and have some kind of online healthcare system where you can access your detailed records. Have we solved this one yet, Sylvia?
I think the technology to do it is out there, but there are a lot of security and ethical, concerns about that, and we've talked a lot about that as well. I mean, who has access to these records? Well, with the patients themselves, have control over them, over who gets to see it or not. So yeah, short answer is I think the technology is there, but whether how we should use it responsibly and ethically, it's a problem that I don't think we have solved yet.
And if I may, just to jump on that, it's the fact also one of the biggest issue. It's also to identify the right person, because we are talking about the ethical part, but how you make sure that the person that you've seen in all these countries is the same person that started the journey, that's also very difficult.
You want to comment on this?
Yes, maybe just to complement a little bit, because we are, yeah, indeed talking about the medical aspects, but we say the migration is a bit of a complex phenomenon where there's actually it comes very striking from the answer that you gave. Safety's connection to protection. Protection is a bit larger than medical care because it tackles the legal rights to be protected, the social aspect. For example, when our teams have projects on the consequences of violence on migration, sexual violence, there is all the aspects of protecting the survivors of violence, which goes indeed beyond the strictly biomedical or mental health aspect, but goes really more in the society. And actually, in that sense, indeed, technology can help, but it's a mentality and it's a mindset part. It's a culture, let's say, that is actually connected to one of the risks that the migrants face. It actually, I would say that is the major risk, which is the policies and the political aspects. So there's a part of the documentation that MSF provides through operational research and advocacy, through testimonies and medical data, is actually to document the violation of human rights that the migrants face along the route, and to document the conditions. Imagine, for example, the detention centers in Libya that are sadly famous to be actually places where violence is perpetuated to the level of torture, and also the policies, restrictions that the migrants face when they arrive actually in Europe, because even in Europe, unfortunately, there are these kind of restrictions. Most of the now we are talking about migrants as a large category. Of course, refugees and asylum seekers, when they have the possibility to access the legal pathway, they can stay in safe place. But there's unfortunately still a large majority of people on the move that they don't have access to this kind of protection, that they live actually in our cities, the so-called undocumented migrants that unfortunately live in conditions often in squats or in places where huge proximity without access to safe water, and these conditions again increment their health. But again, I would just wanted to shed the light a little bit on the policy aspect, to the structural violence aspect that is at the core of most of the health conditions of the migrants.
It's interesting here in Luxembourg. It sounds like it's an accueil, it's a welcome. People are aware and people come to the clinic willingly and are welcomed. That's absolutely not the case in many of the countries that we see along the route, where we're actually running around the forests with loud hailers looking for patients. And so it's flipped it around. We have to go looking for the patients. Sylvia, do you want to talk more about that?
Yeah, and you know, and I'm sure that many of us have also seen the photos of the MSF ship that goes on the Mediterranean to do search and rescue missions as well. And in many different cases, like I remember working on a project that is a cross-border project with Myanmar, where healthcare was not delivered by any clinics or any ambulances, but really by people with 6 months of some medical training, who's going into the jungle and providing care. And so yeah, and it's kind of like amazing the kind of situations that people are in just because of conflict and civil unrest. And it's amazing also like what people have gone through, like, you know, going on the move from one place to another. So yeah.
There's been a strong role, I know, for MSF at least, to document, as you were mentioning, Umberto, the violence that people have experienced, and then provide medico-legal certificates. Maybe this is something you do as well in Luxembourg, if you come across cases where, and you provide people with the legal documentation necessary to prosecute a case, if should they wish to do so in the future.
We can do that as well. So the medical doctors that are seeing that there is a pathway to call for somebody from legal medicine and so on. What we have done also, because what we see sometimes is happening, that you have this violence that coming from outside, but you have families or couples coming, and then there is internal family violence as well. And there is really recently, like last year at the end, here in Luxembourg, there is a center for violence, which is open for all the Luxembourgish people, but also for migrants. So there we already have migrants coming because they are housed together with, sometimes we don't know if it's not trafficking or some other. So they are together in the same shelters, in the same housing, all together with the one that are perpetuating the violence. And there we try to extract them, and we have a system very clear how to take with the police and so on. So there is a full follow-up, and again, we have strong associations that are doing the right thing for these people, associations that are supported by the state in order to specifically help migrant population.
Yeah,
it's really, I think, in Luxembourg, it's something that you do not have it elsewhere.
Yep.
But really, it's really, we want to give the same care on even better than for the local population, because there is a different need in there. It's not because it's something extra that we want to give. It's really a need over there.
With the way the system works. There's language barriers, there's cultural barriers, and so you make an effort to make it as welcoming as possible.
We try to do it to the best, and really is the most challenging, rewarding as well. And as I said, it might be some risk that we have some taking advantage of the system, but we try to make it towards the people that really need it.
Yeah, absolutely. We've got a couple of videos which show the experiences of migrants, I think. Sonia, good luck pressing the right button. No, you're doing very well. Here we go.
Some time ago, I was very scared. When I was on my way coming to Italy, in Libya, there are these kind of people, they can kill at any time. So we are always scared. You will be scared to even eat. You can't even eat in peace. You can't sleep well. You are scared of your life. You don't even know if your life is like 50-50. So you are, either you live or you survive. So you are scared if you're going to die, or you're going to continue your journey, or you're going to remain where you are in captivity.
Damn. Well, we got the first start of that, so that was good. You get the impression, and mental health seems to be coming back.
Went to Tunis, so she passed a lot during this journey. She was being treated inhuman.
Facciamo in questo progetto una presa in carico multidisciplinare, perché la parte, per esempio, medica non è scissa da quella psicologica, e lo stesso è per la parte sociale. Quindi se una persona non è autorizzata a stare in Italia perché non gli viene riconosciuto il diritto di rimanere, chiaramente sarà molto più difficile lavorare sia sul passato, ma anche su quella che può essere una prospettiva per il futuro, che in qualche modo lo aiuta a lasciare andare il passato, perché se lascio il passato da qualche altra parte mi devo aggrappare o al presente o al futuro. Se non ho la possibilità di farlo, diventa difficile anche lasciare quel passato che è molto pesante.
Due to her past life, she was unable to make choices for herself. She was being forced to do things that she was not willing to do, she never wanted to do.
Lei è stata accompagnata aiutandola a stare di nuovo in una relazione di fiducia, aiutandola a rivedersi come umana e come persona portatrice di diritti soprattutto. E forse la gravidanza è stata anche risultato di questo lavoro suo di riscoperta, anche di mettersi alla prova. È stata una sfida con se stessa, con il suo corpo, con questo corpo rotto, con questo corpo che sentiva distrutto, che ne aveva subite tante, e quindi il poter dare alla luce una vita è stata veramente una conferma di quello che lei ancora era, del suo essere sopravvissuta veramente, quindi di essere ancora persona, di essere una persona che può dare, che può creare, che può generare e che si può fidare, che è sempre difficile, però si può fidare, oggi si può fidare.
I'm in heaven because living a life of freedom is the best thing that someone can ever have in this life. Freedom and liberty.
Mental health is coming back again and again and again. It's very interesting to see that. And Radu, I'm imagining that mental health is something that you pay attention to also in the context of the clinic. You touched on it earlier, but perhaps you could expand earlier.
Yeah, so I think that what will come, and I hope that will come also in Europe all over, because there is one European directive now that is for, yeah, it's in French, is accueil. I like this word. I think it's very welcoming. And this directive will be implemented in the Luxembourgish law, but I presume that will be done all over the Europe. And one important thing that it's in there, it's identifying vulnerabilities. And that it's something that we will need to work a lot on it, especially. So in Luxembourg, we are really already designed a system of support, a long-term support for people with problems. And we are really, the hazard makes that we are really in the phase of testing this system, because we have a transitory phase where the service that I'm managing together with my colleagues will be kind of redirecting based on the needs, whether it is only psychologist, whether it needs psychiatrical support, whether it needs addiction support as well, because those are one of the three main aspects, whether we talk alcohol, drugs, or whatever.
Yeah.
So those are pathways together with the associations in order to have the best follow-up and treatment, and long-term treatment, not short-term treatment.
Yeah, absolutely. Thanks very much. You want to touch on mental health again, Umberto?
Yeah, maybe just a quick comment on the video, because unfortunately the first part, which was like the actually testimony of one of our patients, was blocked. So the video showed actually a project that we have in Palermo in Sicily, which is a clinic for survivors of torture. So torture is actually one of the worst phenomenon that can happen in the migration route for our patients, is intentional violence that is perpetrated to extract money from the migrants. And actually torture happens most of the time along the route, but the experience of torture triggers element of violence also in the so-called hosted country. For example, when the migrants face, and it's said into the video, the denial of their right of asylum, re-traumatize and reopen the experience of violence. Now, MSF is experimenting a multidisciplinary approach to survivors of torture in Palermo. Multidisciplinary in the sense that being torture a complex phenomenon that tackles the body, so physical consequences. Imagine, for example, the cigarette burns on the body done by the perpetrator, mental health, so heavily impactful with depression symptoms, suicidal attempts, and so on. But there's also social components, and I think that the video shows this very interesting, the fact that the perpetrator of torture exercise violence also on the identity of the persons. So our patients arrive to our clinic with indeed a need of medical and mental health care, but we arrive again to the aspect of the protection. So recreate a new safe environment in this country or in the country where they are. So our team in Palermo are actually working with local organizations, but also with the public institutions in order to recreate this sense of identity. Now, in the case of the video, was beautifully created through the pregnancy of our patient that actually found a new life in Italy. And this model, this multidisciplinary model, is actually under research. We are conducting an operational research on that to understand exactly what are the possibilities to actually use this model of care, complex model of care, also in public institutions. As I said, our clinic in Palermo is in connection with the local hospital. And I think it's a good example of an operational research that can create scientific innovation from one end, but also have a specific policy and practical impact, hopefully changing, let's say, the approach that the survivors of torture are taking care in our countries. And actually, if you are interested, we can at some point discuss kind of model.
Certainly we can discuss on
doing
that.
a little advocacy on this.
Yes. Yes, absolutely no problem. What was also interesting in the video that you are talking, it's also the fact that the lack of trust, that they don't trust anybody. What it's interesting that wherever we take about the healthcare in general, they still do trust MSF or whatever medical, generally they do trust the healthcare system in general, because wherever they go, they are treated, hopefully, okay, they are never, yeah, the violence never comes from a medical system, whatever medical system in place.
I've spoken to migrants myself, and they tell me that the MSF flag is a continuum in their journey from where they start to where they end up. And that's always a welcoming sign. They know that they can go there. Let's hear from Uriel. Go ahead.
MSF in Poland is working side by side with civil society organizations, and this is quite a special aspect of our work in this setting. Since the outset of the crisis in 2021, the Polish civil society set up bases along the border to support and provide humanitarian help to refugees that cross the border. And MSF built up its activity to support this kind of response that was already in place. It's important to mention that the response is extremely complementary. MSF is providing only one lens of the needs of this target population, which is health needs and referrals when needed. And the civil society organization have, on the other hand, cover all the humanitarian package, essential food and non-food items, and furthermore, the legal aspect, which is essential in this situation. During our interventions, we have been able to create a sort of a package of essentials to satisfy medical needs in the forest. We have created a kit that addresses the most common medical emergencies, and we have been training civil society organizations on how to use these kits for these events. We trained them, we provided these kits to all the bases, and they are nowadays able to carry out most of the basic needs intervention on their own. On our side, also, we were able to learn how to work in difficult environments where the localization even of the target population is difficult, how to handle the security management in a context where even communication is extremely scarce. And the environment is harsh.
You can see the adaptation that has to take place. We're moving out of the clinic, out of the hospital. We're going into essentially a forest, barbed wire everywhere, freezing cold conditions. We're facing different types of injuries from the barbed wire as well, several nasty injuries from barbed wire. Please, Sylvia.
No, so this was a project that I was actually working with the team there, and it's exactly right. Everything that you see in those photos, from the puddle of water to the razor wires, it's a way to inflict an injury on a person traveling through these lands. So, and I also wanted to raise home the point that, like, one of the more sort of like important features of the project is this is also very rare with MSF in other different countries, where we're actually working so closely with civil society organizations, and it's amazing to see everyone going out in a car and stopping and just heading into the jungle with these large, not jungle, sorry, the forest, with these really large backpacks that contain everything to blankets, dry jackets, dry shoes and socks, food, and medication and such. But one of the more interesting things, and I think Umberto, you would like to talk about this a little bit more as well, that is very striking for us, it's the kind of like potential criminalization of these activities here. The amount of, checks by the border guards, the checkpoints that you come to in some of these areas, it really is something for me, being here in Europe, like I've just not seen before, maybe, So yeah, it's not only that our teams and the people are putting themselves in the same sphere of risk that the people on the move are in, but at the same time, there is another kind of like level of state sanction almost. I don't want to call it violence, but sometimes it also is, from stopping us, like, from providing care to people who are really in need.
Criminalization, Umberto.
No, well, it's definitely a form of violence. Actually, what we speak of often is really the concept of structural violence, which basically means really structural conditions that are at the root cause, not only of the diseases, but also the difficulties and the challenges to provide care. And actually, it's definitely as you said. I mean, organizations like MSF, civil society organization, migrants themselves, in general, all the network of solidarity towards the migrants actually are facing more and more this other layer of challenge that actually impeded migrants for full fulfillment of the rights of healthcare, but also the right of protection. And without going too much into the details, this is actually something that we document as well. One of the most sadly famous, let's say, a case of criminalization, I think it's quite well known, as the search and rescue activities in the Mediterranean from different governments and different policies that have been actually frozen, basically, the activities of MSF and other organizations, which were actually compensating this search and rescue activity of MSF, a gap that was left in general from different institutions in terms of really providing l'accueil of which you were talking about.
How did the Italian government do it? I can't remember. It was because they accused MSF of polluting Italy by offloading clothes or waste or something like this, and they prosecuted us for that. And this was the difference. They didn't prosecute just the organization. They specifically named individuals. So individual staff members had the weight of the legal institution against them. Tell us more.
One aspect of this structural violence and criminalization is the creation of a narrative. And the creation of a narrative that is, of course, negative, is negative towards the migrants, as you said, like bringing diseases. What you're referring to was simply the fact that the media, the general media, they spotted a piece of cloth that was, how do you say that?
Discarded on the floor.
No, just that there was some blood on this this piece of cloth, but actually they created the idea that you see there is blood there is infectious disease, and all the cascade creation of the migrants as a bearer of disease. And these are, as you say, they interlinked then with the organization. The organization as serving, let's say, the purpose of the smugglers, etc. But that's a narrative, because then if you go on actual data, on actual evidence, and there I come, I think, to the responsibility that we have as an organization that is working on the front line, as my colleague was saying, on documenting the reality of the numbers and the reality of the consequences of this narrative. But just to end the story, this prosecution actually ended with nothing. I mean,
hallelujah.
Yeah, our colleagues are
off the hook.
Charged.
Yeah.
Yeah.
Thanks very much. Any thoughts or questions for the panel on this subject of conflict, migration, any experiences people would like to share? You need a breath, huh? Yeah. Let's have a breath. Let's take the time to thank you very much indeed for coming to share your thoughts. It's not going to be a breath with coffee yet, but I'll give you 5 minutes to just relax, talk amongst yourselves, breathe, run to the toilet if you must, and then we'll restart in a few minutes with the last session. And the coffee is coming eventually, but not until 5 or something like that. Voilà. So online, thanks very much indeed. We'll restart in about 5 minutes or something like this, 20 past 4, 20 past 4.
Their heart, their kidneys, their system are a little bit more fragile, depending on where you are, whether it's chronic or acute, but basically their mortality due to diarrhea is much higher. Normal children can compensate, they feel a little bit thirsty, you can give them drink, they slowly get better, but for children with some, they have a higher risk of severe dehydration. And here we can see my colleague, which we work together in this study, the GastroSam, Dr. Hadiza from Nigeria, where we conduct the study. So she can explain what I explained to you, but bringing you to the Nigeria context.
Everybody cross their virtual fingers again.
Hello, my name is Hadiza Alhaji Saina, a medical doctor working in an MSF hospital in Maiduguri. Maiduguri, being one of the places affected by conflict, is not an easy place to work. For over years, we have seen a huge number of children presenting into our inpatient center. These children are severely acute malnourished, coming down with diarrhea, complicated by dehydration. These children usually present from camps, from communities living through years of conflicts. And these children are often very young and looking very sick. We followed the guideline in managing them. We did what we were being trained to do, but unfortunately, some of them did not improve. Their condition never improved, but instead deteriorated. Some developed complications, some unfortunately even died. We kept asking ourselves, are we really doing the right thing? Is this all we can offer these children?
We're doing the right thing.
Exactly.
Was the question that really struck me in that.
Yes, are we doing the right thing? Because then you probably ask somebody, and depending on who you ask, you probably will get the question, that's the guideline you should follow? Or they will say, okay, we were taught like that these children with severe acute malnutrition, their heart is very weak, they cannot tolerate the intravenous fluid very fast, so they're afraid of causing more death. So they are taking more safety approach to say that better not to give IV fluid at all, unless they're really in a shock. You only have to try little by little with oral rehydration. So that's the situation. I'm setting the scene for you because later it's you who will play a little bit to see. So please go again to this Menti.
Menti.com, indeed, and
Menti.com.
enter. It's the same code as before, and there's a couple of questions which we skipped, and so we'll have to see how that one goes.
Yes.
And I'm going to go to Amrish with his phone again and make sure I'm looking at the right questions. There we go. And then which question is coming up on your phone, Amrish? Here we go. And so it says, guidelines exist to help clinicians deliver safe and consistent care. But should clinicians always follow the guidelines exactly in every situation? Well, that question really is level 1. And we've just talked about for the last 15 minutes. So if you weren't listening, shame on you. Let's see what the answer is on there. And I'd just like to ask you, Temi,
sure,
how often as a clinician have you found yourself in a similar kind of situation where you're thinking, hang on, what I'm seeing here and what I'm being told to do by the guidelines, this doesn't make sense. This doesn't add up. My intuition is telling me as a clinician that something is wrong. Is this a regular thing or is this quite unusual?
Well, I would not try to quantify it, whether it's frequent or rare, but for sure for these particular questions, a lot of MSF frontline doctors, nurses would question this actually, because these guidelines of not giving these guidelines of not allowing to give IV fluid has been questioned. But then again, it's something that has been entrenched in practice. It's in the WHO guideline for 30 years. And actually, this is the point of this question. What do you think? Because I see majority answering, it depends.
It depends.
Because maybe also to put it correct, what is a guidelines? because guidelines should be like a summary of the best evidence at available time. So it means it should be built on evidence, yes, but what kind of evidence are feeding into this guideline? It's true there is not one single study or one research that will just change everything. It's all, that's how science works. You contribute, you're building on the base and so on. So in this situation, yeah, the answer is more or less, it depends, because even this curiosity, this kind of questioning, why the outcome of the guidelines is like that, and what you observe different, that's the seed of doing research as well, actually. I'm trying to bring you there.
That's clear, yeah. So should we go for the next question then, Temi? Yeah, the next question, which says, and here again, wandering over to Amrish's phone.
Now we
there we
managed
go.
to put it there.
If child mortality remains high, despite correct guideline implementation, what is the most defensible interpretation? So is it the quality is still insufficient, the resources, evidence doesn't fit the population, random variation, all of the above? Temi, I think all of the above is going to win eventually.
But in a way, this question is answering, is saying it in another way what we saw before. Because even if you follow the guidelines, say, okay, I will give slowly the Resoma, the low natrium specific oral solution for these kids, the mortality will be low. But then what we see is not the case. So what is behind this? Okay, it's true that there is a story about implementation. Implementation varies from resources you put, human resources. Do you really have enough nurses on the bedside to explain to the caretaker how to give the ORS slowly? Do you have electricity to put, do you have the infusion pump? So the correct answer is all of the above is true, because it's true that probably it's linked to the implementation problem. It may link to the resources that are inadequate because there's not enough staff in certain remote places, or it's possible that these all are the causes, but it also doesn't mean that you're questioning the guidelines was wrong.
Yeah, okay, let's have a look at the next question. Who most often identifies the operational gaps that therefore become research questions? Is it universities, so academic institutions, global technical bodies, donors, as in donors of money to MSF, I'm assuming that must be, clinicians and program teams, or affected communities? And so I can see the winner is going to be clinicians, because they're one at the front lines and they're the ones who see the discrepancy between the guidelines and the reality.
Yeah.
And hence the question that I asked you only, do you see this a lot? And so you see this sometimes, and you see.
Yeah, we see this sometimes because it can happen at the clinician level, meaning like we say, like the example we said before, the guideline says something and then the outcome is not commensurate. Or it can also be in the program that you actually want to reach your coverage to a certain number, but then you don't reach there. So there is always a gap that what you want to achieve. And this is the gist of the research that MSF does, because like we said from the beginning, we are in the front line, we are taking care of these patients who are the most vulnerable, basically. So we have access to this population. Doesn't mean that we become opportunistic and have to do research to all of them, but when we see that what is the normative and then what is observed to be different, we try to listen a lot to the project and clinician frontline to
but
observe
also
this, yeah.
affected communities. I see this a lot, particularly in the UK press, that patients say, hang on, we've been given this treatment path and it's having this results or these side effects, and that's not necessarily what we expected or were told or what warned about, et cetera, et cetera.
Yeah.
And so do we speak as well as an MSF to communities to discuss with them the healthcare that they're receiving and the impact that this is having?
I think we are starting, because you're right, in the ideal world, what we should research, what we should put resource on research should be defined collectively by the patient who are affected, so not just by clinicians, experts who sit somewhere else in the university and decide, I want to research this, without asking whether for the patient is the most important pressing issues for them. So we are trying, I think as MSF, to try and more to involve the affected patient population or communities into the design of the research. This is something that can be done. I think my colleague Umberto can speak more to that, what we call participatory research. But on the other hand, I think from healthcare perspective, it also makes sense that you cannot just go with your interests without taking into account the perspective and the lived experience of the patients.
Yeah, okay.
Yeah. And in research, happily, fortunately, it's slowly shifting that way.
Good. It's good to hear. Okay, so question 4. When research resources are limited within MSF, the organization, what should guide prioritization? So how do we choose which operational research projects to fund? Because we have many choices. I'm assuming, Amrish, I can see you nodding. And so do we look at the potential total population impact, the severity of the illness, the equity consideration, reaching the world's most vulnerable, or cost effectiveness? And if you were a pharmaceutical company, you'd be answering cost effectiveness, I'm assuming. But here, potential total population impact, so more kind of public health.
Or
That's
like
what
a
seems to
global
be
burden
coming.
of disease, like you probably you want to the disease that affect more people, basically. So you quantify that, including for the population impact answer, because the answer, there is no correct answer. You are right that all these reasons, all these prioritization component are depending on the ethical framework you're trying to see. If you're a utilitarian, sorry, I'm using that word, but if you want to reach more people with a little money, you probably will use as a benchmark, I will prioritize the one that affects more people. If we say malaria, 70% of our project has malaria. That's probably we should also try to improve quality of majority of our project. Nutrition, we take this example because this nutrition crisis is increasing. We really have a huge project with taking care only all these severely acute malnourished children. We also deal with disease like Ebola with high severity of illness, meaning the number of people affected may not be large, but the case fatality rate or the mortality from that disease is very high. Cost effectiveness is like vaccination, meaning you try to implement a public health intervention with the biggest value for money if you have a donor interest. But again, I think it's important for us to say here to differentiate. That's why our research is not driven by just like purely academic to win the Nobel Prize, not at all. Or on the other hand, like creating new product R&D that will eventually be sold and have a profit back. This is clearly not the ethical drive that lead to MSF prioritization in terms of research.
Okay, thanks very much. Next question then. In reality, what most often limits operational research in humanitarian settings? Is it the logistics, the security of the things, the staff capacity, the ethical oversight requirements, funding flexibility, or community trust? We touched on much of this with the introduction, so let's see. And the answer, of course, is all of the above, and you can see that from the outcomes. Can you give us a personal anecdote, Temi? Is there one that particularly impacted a particular operational research that you worked on?
Yeah, it's true for each of these. There will be example that can be shared.
Share one from your
by
personal
LuxOR,
experience.
But I think, for example, many people, I can say, for example, maybe come back to the Cox's Bazar before, which is like there is a barrier in terms of the ethical research requirement.
So we're talking about the in forced displaced people's camp, the refugees that come across the border in Bangladesh from Myanmar.
Yes, yes, exactly. So they're put in a camp that the Bangladesh state wouldn't consider them as Bangladesh population. They're like people who has no status, the stateless people. So when you seek to seek ethical approval from a body that makes sure, apart from MSF Ethical Review Board that we already said we have as an independent body, and then they will say, no, we don't take care of them because they are not our population. So of course, this can be mitigated, but it will take longer time because we can explain to the MSF Ethical Board, which is very open to dialogue, that, okay, this is the situation in Bangladesh, and then there will be other authority that can provide. But that one example that came to mind where sometimes the research timelines may be different from operations timeline as well. So you need to be patient because you also face all this logistical and security, which is maybe the same like other project, but yeah.
Correct. Let's keep going. Next question. Oh, is that it? We'll go back to the slides then.
Yeah, I think those series of questions really to try to put you in a set and then see how the research question can start.
All right.
And yeah.
So you take us back to the situation where we have a clinician who is seeing a difference between what they're reading in the guidelines and the reality they're facing in the outback. And that was illustrated by our colleague from Nigeria, Maiduguri in Nigeria. And
this is just to have a little more in depth about the GastroSum trial. So it's a breakthrough trial because it's the first trial that is conducted in sub-Saharan Africa exactly to refine that question. So the question that we heard in the beginning, is this guideline good enough? It became like, what is the safest and most effective way to rehydrate these malnourished children with diarrhea? That's the question we try to answer. And how we are trying to do that. Yeah? Sometimes MSF also, we hear from the beginning, we need to partner, we need to collaborate, and this is how we collaborate with the initiator of the study that started first in Kenya and Uganda. Not typical MSF site there, but they don't have to, they're there, but they didn't have too many malnourished children. While MSF is flooded in Maiduguri, as you see, the Niger and Nigeria, they're both in the Sahel. They are affected by lean season, by a lot of also insecurity and so on. So this study started in 2019 and was just completed last year in 2024 and was published in 2025. So it was to show that MSF could contribute to the important research because we have access to the population. But let's hear also Khadija. Is that a video?
Yeah, we can hear the video.
Over time, we came to realize that this wasn't just a Maiduguri problem. Other teams in other places also passed through similar challenges and kept asking the same question. The guideline we had was based on old evidence, and in some ways it kept holding us back. I knew something needed to change, but as a frontline physician, knowing that a question matters and knowing how to change it or how to turn it to a study, these are two very different things. I didn't know where to start. And I think that is true for many of us working in this setting.
So I heard her say that the guideline held her back. That's what I heard her say.
Yes, exactly. And she was saying that she knows that this doubt, this question on this are not hers alone. There are many places where they share the same, but they don't know where to start. They don't know who should I know, who should I look up to this guideline? You go to the WHO guideline, World Health Organization, and you will see this is being recommended, although you will see that the level of evidence is weak because it's not based on very good study. So, or based on expert opinion, or like I said in the beginning, more like cautiousness, try to not to increase the mortality by being more conservative in terms of treating your patient.
So you launched the study.
MSF is very proud, yeah, with the help of LuxOR. That's what we say. Our start was to try to compare, because this is how we should do a study. I mean, operational research in MSF covers documentation, as we say, from routine data, but we also do a trial like this where we investigate the guideline, which is the oral rehydration, which WHO says, you just give oral and that's it. And then we try to compare it with the IV, with the intravenous therapy. First, rapid, meaning is how you will treat a non-malnourished children. And then the other one, we know, to alleviate those who are freaking out about this study, also to say, okay, we will do an arm of slow IV, meaning a liberal strategy, like also the same amount of fluid you give to non-malnourished children, but slower, exactly. Not the first 2 hours, but a bit longer. Yeah. So this is our study design as a illustration. I think next, that was the question. And now that you know the trial, you know how we do it, we recruit in 4 hospitals. I guess now there will be the next question with the same mentee. I think it should appear.
Ali Emrich, I come to your telephone, which says, if concerns about intravenous fluids were correct, which group should have, according to the theory, the highest mortality? You can see oral fluids, slow IV fluids, or fast IV fluids. Indeed, yep, I think that's the answer you're expecting, Timmy. Is that correct?
Not yet. There's not enough quorum. I will wait for 30 people. But you're right. So maybe to remind, the guidelines say IV is dangerous. Don't give IV because you will have high mortality. That was the pretext. And we are trying with this study to try to prove or disprove. We have a hypothesis, and then we will try to prove it. And I think majority are right. Yes, this is what we expect.
Okay, and so then I'm
Smart
assuming
ideas.
there's another
Very
question
good.
coming up now.
Yeah.
Okay. It's coming.
And actually, it's to show the result, whether you guess correct or not.
Okay.
The outcome of the trial. So what did the trial find? As I mentioned before, the trial was finished. And then actually the endpoint, or let's say the outcome we tried to compare in a rigorous way, was the mortality at 4 days, at 96 hours. And we can see, I think the oral has 6%, the slow IV is 7%.
And you're in
No,
trouble
the
now because
8%, sorry.
the Zoom control bar is covering your.
The answer,
your
but you can see the red represent the mortality.
So this makes me worry that have we done an operational research study and have we increased the mortality rate because we've made clinical choices which have increased the mortality rate? So
No, because with this result, you do show that if you follow the guidelines, our mortality is actually the highest, 8%, and the liberal one is less. But to those who are interested, I can share you the detail because this looks different, but the difference are minimum. So actually, there is no difference. We couldn't prove any significant difference between this group, basically. They are the same, but you can also say it means giving IV is as safe as giving oral. Basically, you are not killing more children by giving IV. You are giving them as safe treatment as you would have followed the guideline with oral only.
So you begin to wonder, why were these guidelines written in such a way in the first place?
A lot of people are questioning that, and there are many reasons which I can divulge in a conversation after, but it's also to show that changing guidelines are not so easy. These are based on, like, as I said, 30 years of expert opinion. Maybe there are different level of evidence that you could balance whether changing guidelines here or not. But for sure, this is starting a very needed discussion, whether the guidelines are.
And you keep mentioning guidelines. Perhaps it's interesting to point out that there are guidelines written by MSF, and those are easy to change. You just look at the name of the author and you email them and say, hang on, you got it wrong. But if you're talking about WHO guidelines, it's a lot harder. And it's really those ones that have the highest impact, if I understand correctly.
Exactly.
So you want to have an influence on World Health Organization guidelines because these are the ones that are most used.
Yes, and when I was referring to the guidelines saying do not give IV, I'm referring to WHO guidelines because most of the time MSF clinical guidelines are aligned with WHO guidelines, and if not, it has to be with a proper justification. And exactly for this study was take a lot of time of convincing our MSF program to say that yes, MSF can be involved in such study. Yes, our team can be trained to do this, and yes, the impact will be huge because it will change both MSF guidelines and practices and also WHO guidelines because this is the type of evidence that they are looking for.
Carry on.
So we know the conclusion, death rate in children. So yeah, basically this case study or this gastrostom trial tried to summarize.
Don't worry, you can move, Sonia, around that little control bar bit by bit. She's going to start at the top with observation.
This is a mentee question for you initially, but I know we are coming to the end, so we'll try to also mindful of the time. But I think based on what we see from the beginning, we see that there's observation. There are identified challenge and gaps. And then we see, should we do something about it? Yes, there's a question that arises. And then we try to refine it. We try to see what methodology is suited to that question. So the key research questions are developed. Then the study will take place itself. I mean, we implement the study, we collect the data as we hear from the two different topics before. It's collected and analyzed. And in the end, through analysis, we generate the evidence, be it not just scientific paper, policy brief, conversation, webinar, anything we can do to try to actually to trigger and to stimulate the change in practice and
does this story have a happy ending? Have the WHO guidelines changed?
Not yet, but we are in touch with them.
Not yet, but.
Not yet, but we might hear it very soon because, yes, because there is a whole system behind changing the guidelines.
Are we demonstrating outside the WHO guideline building with placards saying change your guidelines?
In a way, this is the role of MSF, I think, partly with the témoignage, because many people will be daunted to do this trial because they say, there's not a new product, it's difficult, like a lot of hesitation, but then MSF could step up and say, hey, we could contribute to this with hopefully longer impact, which maybe next year we can say that the guidelines
earlier,
really
Amrish was talking about the fact that it's not necessarily one paper or one study, it's a body of work that contributes to a growing amount of pressure. So can you see MSF doing more research around this to really nail the
I think,
message
as I
home?
said, GastroSam is also not a vacuum. It's also just one trial that are built on many other studies that we have done in nutrition field. It's also built on other partners who have done a lot of studies in there. So I don't think MSF can claim anything with this, but maybe to answer your question, yes, it's not the only study because it's a series of findings that need to be discussed, need to be leveraged. We still are going to Nigeria, to Niger, to each country to speak with the stakeholders, to discuss about the results, because it's not just also some finding and then people will, adopt it or uptake it easily. And that's the tough part. That's why I think it was good to mention that publication is never the end story for MSF. It's not our milestone, our last mile, but it's more how it can actually change practice and policies.
Fantastic. Well, thank you very much indeed, Temi, for sharing the story.
Yeah.
And congratulations for taking on the World Health Organization. I understand it's not easy to take on the World Health Organization.
Inshallah.
Inshallah.
But I thought there's last question that is quite nice.
Okay. And so how long, oh God, how long does operational research typically take to influence the global guidelines? Is it months, years, 5 years, 10 years?
Maybe we give away the answer, right?
And I think I'll throw this one back to Amrish, and because I think in some cases the cycle can be quite quick if there's demonstrable evidence and you can really prove it, but in other cases it can take longer.
I think everybody remembers the pandemic, where research was being done in real time, the COVID-19 pandemic, where research was done in real time because you're dealing with something with high levels of uncertainty. A lot had to be done on occupational health, and I think everybody, either you're being a medic or not a medic or researchers, everybody tried to understand interventions that have such an impact on the community. How effective are they? How are we justifying them? Guidelines were written on the fly. Also, how do we keep each other safe? I remember I was very lively engaged in the discussion on the use of face masks in the Netherlands that never wanted to adopt them despite WHO recommending doing so. That also kind of testifies to the fact that things can go very fast, but also there is scientific diversity. Science can provide evidence, and we try to do that in the most neutral form, but that's when the engagement starts, which is often highly political as well. Politicians also have interests that might deviate from public health or global health interest, and actually that's also part of our job, to try to influence that. And it's not just our job, it's our responsibility quite often. And that's, I think, what I also often pride ourselves in as MSF, that it's, yes, the science is the fundament, but then we need to go to the next level to push for change. And yes, even if it takes 10 years, MSF has also a good reputation in HIV and AIDS research, where a lot of milestones were really kind of driven, where we need to work with partners to kind of keep on pushing that narrative. And like I said, especially today, where science is, many academics call science is under attack. There's a lot of science skepticism. It was very rare to hear politicians openly criticize science and scientists, or the criminalization of healthcare, not just something that MSF faces, but also what physicians face also in European countries. It's now become a common problem. So in many aspects, public health is activism. And we should not step away from activism as well. And we can do it in many ways. First, the science needs to be solid, and we need people to focus on that. But then we need to also people to bring it to the next level, to do that advocacy. And that's also something that we do together with a lot of our partners. And why maybe you all came here today as well.
and why we're here today, because we're celebrating 40 years of MSF Luxembourg, 50 years, 52 or something like that of MSF. I can't remember exactly when we started. And because, so maybe one of the answers on that thing should have been 40 years or 50 years, because it takes time. Bon. Here we go. One word. What is operational research? Essential, powerful, real research, help, keep going, involved. There we go. Strategic. Yes, it is strategic, certainly. A great thing. Well, there you go. That justifies your job straight away, Amish. Progress. I like the idea of progress. Is absolutely progress. Progress for the patients, that they get better healthcare. Impact. There we go. I'll leave you with that word, Amrish. A final word to close before we hand to Sonia for some thanks.
No, it's often perceived that research is a side activity, something you do because it's maybe nice to have, but it's not really relevant. But in medical work, or in your organization that works in public health or global health, research is really pivotal. We deal with resource scarcity. We deal with the complexity of the socio-political domains entering in there. And there's always too much. There's too much to deal with. So the necessity of partnerships with other academic institutes, national public health institutes, is really important to kind of deliver impact of our medical programming, to keep us accountable in doing things the right way. Are we, like Tammy showed, actually doing the right thing? Are we not, keeping ourselves small? Should we not look at expanding the options of interventions with more diseases making a re-entrance, all diseases coming back, and a political landscape that is more complex? And very happy that so many of you actually attended today, because as researchers, I must honestly say, we really feel comfortable in scientific conferences, and public events are a little bit always complex, like, will people really think research is a sexy thing? Sometimes yes, most of the time not per se. But for us, it's of course also our duty to make research understandable, because in the end, everything is, on research based, any innovation, if it's medical or if it's anything else in electronics, your mobile phone consists of over 500 different technologies invented all over the world and brought it in a relative powerful device together. These devices we can maybe utilize in the future to improve diagnostics by taking a picture of a malaria slide, for example, to fastly looking at patterns of antimicrobial resistance. Solutions that didn't exist 10 years ago, but are there, and will probably take another 5 years before we finally adopt it in an operational fashion. And I think it's really important, because I saw something coming back of operational research is real research, but I always want to be a bit careful about that. Curiosity-driven research is also really important. Some of the best and most important medical inventions, like the first real antibiotic, penicillin, were discovered by accident because someone was curious and stared at a Petri dish and saw that, hey, if you add this extract, these bacteria kind of stop growing. And we pluck the fruits nowadays from these type of curiosity-driven inventions. So in general, I never try to say it's academic research or fundamental research versus operational research. We need more funding and support to research in general. That's how we progress as a society, and everybody can benefit from that in the end. So thanks for being here today with us and listening.
And thank you, Sonia, for organizing it all. Well done, Sonia. Bravo, huh?
Thank you. You hear me? Well, thanks to everyone, and thank you for being here. And I would really like to thank our speakers, and both from the team, that they are not all in Luxembourg. And here, I think that was nice, because we really saw that actually, even if we are not researchers, we are all affected the same way wherever we are in the world, whether in Luxembourg or in the context where MSF works. Especially in Luxembourg, we are all migrants. I mean, most of us. And I think that it's good as well to remember that. And yeah, a very big thank you to all of you who stayed 3 hours listening to research topics. So a big applause for you. And there are some good drinks and snacks, and a special thanks to Radu Duka, for Dr. Radu Duka. Yes, please, to come and spend some time with us, and to Henri Michel, who had to go before the end. But a very big thank, and I hope this will open the way to further collaboration with Luxembourg and with others. And thank you, Robin, because the moderation was great as usual.
En mange.